Thank you for joining us for the reimbursement and coding for screening and brief interventions for clinics, health systems, and hospitals. This is being presented by Joseph Hurley, who is the President of Primary Care National and the Executive Director of Medicare Health Systems. He's formerly employed with the Oregon Health and Science University Family Medicine Department, which is ranked among the top 5 medical school divisions primary care multi-specialty practice. Mr. Hurley's pioneering work has been centered in the role of team-based healthcare, creating successful SBIRT integration and implementation modules, primary care innovations, 5-tier, 3-certified, patient-centered medical homes, accountable care organizations, Oregon's coordinated care organizations, and the expansion of the primary care role as in our nation's healthcare reform. His previous work has placed him with Legacy's primary care division, ranked with Legacy Health System in the top 10% best healthcare international rehabilitation services, this nation's #2 durable medical equipment suppliers. Children's Hospital of Orange County ranked best in children's hospital and pediatric facilities, and Orange County's primary care Healthy Tomorrow's division. Okay, Joseph, I'm so glad you were able to get on the internet.
Thank you. Yeah, nothing like having trouble the moment before you start.
Can you speak up a little bit?
No problem. I said nothing like having troubles the moment you start and having no troubles the entire week. Great. So the discussion today is going to be centered around finance, how to bill, but at the same time, a model just showing you exactly how in Oregon we've been able to be very successful with the reimbursement for SBIRT. As I started creating this presentation, I realized sometimes explaining a little bit the innovations we've done and how our providers, by working with them, we helped create this innovation. It really explains the billing side. So as was just explained, I was lucky to be a part of a great thing in Oregon with Dr. John Munch and Jim Winkle. Jim Winkle is the project director for the SBIRT initiative, and Dr. John Munch was the behavioral health director over the Oregon Health and Science University, and also the grantee by HRSA for SBIRT. So during this presentation, I am okay because we're going to have 3 hours. Hopefully you've got some sort of energy liquid beverage, as well as if you have any questions during the presentation, feel free to ask during the presentation. You don't have to wait to the end. I really would like to, if you have questions, answer them as quick as I can, and at the same time, be really attentive in that. So just as a heads up, I just want you to know that there will be medical billing or clinical acronyms used. So if I start saying things and you don't quite follow, please feel free to raise a flag, or at the same time just type text into the person who's also helping with the presentation so that I can quickly explain it. I really, during these presentations, been trying to catch these things, but if I do happen to say a medical acronym that no one understands or has not heard of before, please raise a flag or just tell me to slow down. So I just wanted to kind of explain a little bit about why I'm here and why I'm talking about the screening, brief intervention, referral for treatment. If you have a second, this is very rare, but if you just type into your, not now, but maybe a little later, if you just type Oregon, oh, there it is, SBIRT, you'll go right to our website, the very first, and you'll see reimbursement. All of the things we're talking about today, they're here and they're free. So we'll be talking about screening forms, our clinic workflow, clinic tools, even our entire training curriculum and our reimbursement model. All of that is listed here free. And from videos explaining, you could click the demonstration videos that walk you through how a provider can talk with a patient. From videos you can click that actually demonstrate how we provide our SBIRT at Oregon Health and Science University, to our screening forms, which you can download for free as a Word document to change them to match your clinic, or just as a PDF if you want to use them. We even have our clinic flow, which you can click on, and it takes you to each icon. It's on here, as well as our, like I said, our training curriculum. It's rare when someone presents and says it's free, and it's not. This is a free lunch discussion. Literally everything we've done is free on our website. So all you have to do, in case you can't remember, where I pointed you to on this PowerPoint, really all you have to do is click in Google Oregon SBIRT, and it'll take you to our website. Just to give you a little foreshadowing again, our SBIRT started really in the outpatient primary care setting. And then once we realized how successful it was, we moved it into a hospital services. And then from our hospital services, like inpatient, we moved it into our ED or ER room. So it's interesting how we're one of those, Oregon Health and Science University, it is one of those integrated healthcare models where primary care is integrated into the health system, as well as where the health system is integrated into the inpatient. So one of the few things I really hope to talk about today, really every state, you're going to face certain challenges with doing SBIRT. The challenges with reimbursement are some of the payers, since it's a new code and they're thinking, well, this is an added cost, might not be too impressed on paying for SBIRT. You're also, one of the real important points we could make is that by performing SBIRT, we're actually reducing clinical costs and actually helping save the bottom line. But it's, I'm sure insurance carriers, as well as certain states in their out-of-budget or underfunded Medicare or Medicaid or even commercial plans, might be very hesitant to start paying for new services. So really what we've been able to do in Oregon is our initiative was really based off self-funding. So we had a HRSA grant, and then Dr. John Munch said, how can I make this possible to where we can make this self-sustaining? And so really we were lucky as well. Oregon has a very amazing Medicaid system where they were open, they were able to work with us, and we got funding from Medicaid as well as Medicare and all our commercial plans. Some states have not been as open, or the word I like to use, as enlightened as others. And so I know there is difficulty with certain states. But really our goal is, by our discussion today, I want to also build with you advocacy for doing SBIRT. It took a little bit of time for us to really discuss with our private payers as well as get our reimbursement. But right now in Oregon, every single payer is reimbursing for our SBIRT, as well as our Medicaid and as well as our commercial plans, all of them, our self-insured plans, and our Medicare. And what I hope to show you today as well isn't just the reimbursement, but it's creating a platform that I can discuss how we were able to really talk to our payers, get state support, and reduce those barriers. Sometimes when we do billing, we sit down and we create complex algorithms, and really what it turns out to do is frustrate our providers as well as our patients. And so how can we create a billing platform that reduces barriers for patients to get seen, as well as we all know that most of the time when we talk to providers about billing, they get a glazed look in their eye and they instantly are out of touch. They're thinking about treating the patient or thinking about a warm beach instead of thinking about billing and how they can effectively bill better. That's sometimes not the main priority of a provider. And again, the provider is there to provide care to the patient, and they want to do it as fast as possible. And sometimes our billing discussion just turns into, oh, we're another barrier for me to treat this patient. So giving you a little heads up about what is Oregon Health and Science University, teaching institution, ranked really high in the nation. Also, what I really enjoyed in my time at Oregon Health and Science University was their real approach to how can we improve patient care, how can we, as an education piece as well, improve the patient care. And it's a very large $1 million research facility, as well as lots of our providers, almost all of them did community service. And Oregon Health and Science University, it is a major, major economic and social force in the Northwest. I know this says on here 13,000 employees with a $1.4 billion annual budget. I think that's now $2.3 billion. So it has a major push in the Northwest. If you ever had a chance and you're reviewing this, you should have a PDF of this either after the presentation or later next week. You can click on this website, and it'll link you right to Oregon Health and Science University. On the very bottom is a video you can watch, about 3 minutes. It explains who we are and what are some of our recent innovations. So what is Oregon Health and Science University Family Medicine Department? So as our rankings, like everywhere else, go up and down, we're consistently in the top 5 for the best in academic family medicine programs, as well as our primary care. We are one of those we're truly linked into our health system and into a hospital. So we're family practice, but in the hospital, we have our own family practice wings, as well as our own delivery wing, and as well as our own inpatient department. So we are truly integrated with the hospital. And it's really fun because we started just a tiny 2-doctor clinic to turn into this nationally ranked major department. And I know as our providers talk, they're very happy about what we've turned into. And I put a little bullet on the very bottom because if we can do this, so can you guys. One of the things I hear when I go speaking is, oh, you don't understand, we're so complicated. I hope to explain how complicated we are, and we are extremely complicated. But if we can be successful, the odds are anyone else can. So we have 4 large clinics. All 4 of our clinics together see in this year about over 200,000 patients. We have 3 like hospital services I talked about, and we have our own residency program integrated into our clinic and our practice. So we have more than 50 residents. We have a 3rd-year medical school clerkship and now a 4th year, and a faculty of over 95 clinicians, also educators and researchers. And we heavily volunteer. And so we have 5 practices now. We just took over Klamath Falls. All 5 of them they're certified a primary care tier 3 home. Like I said, we are completely integrated with the hospital, and we have team-based healthcare in the hospital as well as at our clinic. Now, we are a completely complex health organization. So again, if we can make SBIRT successful with a bureaucratic, complicated system, there should be no problem why the people here listening can't do it as well. And as I pass on to that, not only do we have different electronic health records integrated within each of our systems, we have completely different ways of billing. And it's kind of interesting. The usual approach to SBIRT is people throw a lot of money out there, or they throw a lot of CPT codes out there, and they try and see what their providers will do. And many of you on the phone, probably you have medical directors who they come to you weekly with new ideas, and so you sometimes realize, well, what new idea actually brings money, or is this one of his weekly new ideas that never really pans out because it doesn't get followed through? That happens a lot. I've taken that from experience. So the main point in our approach to SBIRT, let the providers do what they do best, and that is treat patients. This was the #1 point our healthcare providers said. They said, if you want us to provide SBIRT, then you have got to let us treat the patients the way we want to. So in other words, don't create a complicated billing algorithm that a provider is supposed to follow. How many times do we get lost trying to navigate on when we've got Siri telling us where to go on our iPhones, or we've got some sort of directional system, and we still get lost. Trying to tell providers how to bill is like trying to tell a giant cow to walk into a slaughterhouse. Most of the time they're going to deviate. And so creating something that works for them is really a key here. The second part was our provider said, we've invested millions of dollars into this expensive electronic medical record system. So make it work for us instead of making us work for it. And that was our #2 point. Very heavy. Our platform is Epic. I know Centricity, MedGen. I know a lot of health systems are still on Cerner or they're on NextGen. There are some. All of us have electronic health records that we're using currently, or a large portion of us do. So if we've invested so much money into these complicated, very onerous billing systems, I know the providers are thinking, if I've been forced to use this, then why can't I force this system to make my life a little easier? And so this is something of the points that they brought up to us. And this is actually a little bit why ours model is so different from other states, because we've made our electronic health record work for us, and that has completely changed how fast a provider can document and how fast these services can be done. And that's one of the reasons why Oregon's been so successful as of the other states, because our electronic health record really works for us. So here's that word, enlightened states. I'm not going to be, don't worry, I'm not going to be reading from this PowerPoint. There are some certain things I want to touch on. And this point I make is many enlightened states have taken the torch to improving the well-being of its population. And I use that enlightened because some states, the local payers have clamped down and they've made it very hard to provide services for patients, especially for primary care. Now, when I say primary care, that's a long list of providers. And as this nation moves toward an integrated primary care, psychologists, alcohol and drug addiction counselors, all of these certain licensed clinical social workers, all these people play a key role in what is primary care. It's changing. It's moving, and it's turning into, really, I read a phrase that said, decent primary care, it reduces bad, healthy options for patients. Good primary care saves lives. And excellent primary care enhances patient lives. So as we're moving toward an integrated where it's primary care integrates with behavioral health as well as mental health, there's some really interesting literature out there that shows how clearly beneficial this integration model is. And SBIRT really works for primary care centers, for hospital emergency rooms, for trauma centers, for those federally qualified healthcare centers, those safety net, community healthcare centers, even for rural healthcare centers. There are some state-funded payers, and there's just SBIRT can work in almost any scenario. And really, the quicker we start working and doing SBIRT, the quicker we reduce some really bad patient health outcomes. Number one of them is being accidents. Lots and lots of our trauma centers we're including SBIRT in, they're seeing a dramatic reduction in readmissions as well as patients, the same patient coming back. And that's sometimes scary for hospitals, but I'm going to really show you in our model how our hospital has been able to make a really decent profit as well as improve our bottom line, because these patients who we're screening for SBIRT are being funneled into our primary care clinics. And what that means is we're increasing the patient referral pool and we're increasing our referral source. So what that means is when those patients have complicated surgeries, they're not going somewhere else. They're grounded in our primary care and they're grounded in our health system. So what we're doing is we're actually increasing our ability to treat patients and increasing our ability for patients to be funneled into the surgeries into our hospital and stay there. So it's been an interesting model. So there are some states that have been very successful as of late, Colorado, Oregon, Wisconsin, and other states that are the HRSA grantees. One of the ones I'd like to talk about a little bit, besides Oregon, is Colorado. It's had an interesting initiative where they've had a very large push from federal grant assistance. And from this, they implemented just a slew of programs all throughout Colorado, screening more than 3,000 patients a month. And it's interesting, too, this is a clear point that has to be made, is that the 6-month follow-up by those patients showed that alcohol use fell by 51% and illegal drug use fell by 36%. So this is, and this isn't inconsistent with other states that once they implement SBIRT, this is what we're finding out. So on the PowerPoint or the PDF handout you'll be getting, on the very bottom there are some interesting, you'll see the literature on the bottom highlighted. Sorry for my choice of colors. I was trying to keep people awake during this webinar. I know sometimes, usually my slides I have when I get to the billing part, a lot of sleeping providers because that can sometimes happen as well. But SBIRT really reduces healthcare costs. And for spending $1 and getting back $3.81 or $5.60, that's a pretty heavy statistic to point out. So by spending $1 on SBIRT, you can save $3.81 or $5.60. That says a lot. And if you're a health system, this says something as well as advertising, how you can advertise to patients that I can help save you money, and you can have the points to really, the proof is in the pudding. So something else that is just as important is that people who receive the screenings and the brief intervention in an emergency department or a hospital or even a primary care office, they can experience about 20% fewer emergency department visits. And these are mostly the self-pay patients as well. So when the hospitals hear, wait a second, these patients who are also hard to not the highest paying patients, I can reduce their visits. You also can reduce 33 non-fatal injuries, reduce your hospitalizations, as well as fewer arrests and motor vehicle crashes. So it's just pretty interesting. And I'll tell you that for the providers on the phone, if there are any, it's interesting. So when you get a finance guy like me and a provider together, and you're both on the same page, it's interesting what you can create. And Dr. John Munch, he's all about providing the care for the patient. Very smart provider. He saw what these numbers were, and he realized in Oregon we were lacking this. And as he put together his training platform and sat with me to talk about the financial structure, I was really impressed with his ability to really grasp financials, as well as to grasp how can we create something that is so easy providers can't think of not doing it. And he wanted to, our approach was, as you'll hear later on, was to have billing be behind the scenes. So he's training providers on how to do is to document and to provide the service. And in the way he trains, billing's included and the providers don't even know sometimes. And I'll walk you through exactly how he did this, but how we created this training platform basically was we taught providers how to code without them even knowing it. So when they're doing their services, they actually have been trained on how to code the process. And coding gets complicated as well as with our payers. As we'll talk about in a second, Medicare has different codes for the SBIRT. Commercial plans have different codes, as well as if you have a state-funded Medicaid program, there are different H codes or I codes depending on the state you're in. So it can get complicated. And having a provider on this one small service have all of these different CPT codes, that can make it to where it almost will crash even billing for SBIRT. And in our program, I'll explain exactly how we made it so that not one CPT code was coded incorrectly after our initiative went live and we fixed the kinks in it. So for everyone here in this webinar, I welcome you. My PowerPoint here was, what is SBIRT in your state? I'm working right now with South Carolina, North Carolina, Tennessee, moving into Arizona, and talking a little bit in Washington. And SBIRT in each state is a little different. Some states have barriers from insurance payers on paying. Some states have no barriers. They're just lacking the drive to move forward on initiatives. So for those healthcare providers who are on here, or for those very savvy and smart financial directors who are here, realize that there's two goals here. Your initial goal is reducing and preventing, things that have bad health consequences. Through overuse of alcohol and drugs, you're reducing set diseases that are caused by them. You're reducing accidents and injuries. But the financial guy in this room right now is thinking, well, where's the money in it? Because if providers want to provide, they can't do that if they can't pay to have the lights on in their office. And so that's one of the interesting things about how really good primary care clinics, psychiatrists, licensed clinical social workers, you can't really provide a service if you can't afford to have the lights on. And so this entire process in Oregon was, how can we provide the best possible service to a patient so we can accomplish these goals while still having funding to make sure those lights were on. If I can open up with a question, are there any questions so far, or can I keep going?
We did have a question that we did attempt to answer, and it was from Ohio. They just wanted to know if the information you're giving us is just for Oregon or if it's for other states too, because they were saying that Ohio Medicaid doesn't seem to cover these services. But the information you're giving us is national information, right?
So this information is national. The second part is I can tell you how we in Oregon made it successful. So a few years ago when we brought this up, we were probably in the same boat where our Medicaid said, well, wait a second, why should we really pay? And I'll walk you through what we did to show them why it was so important. But we actually got our state in Oregon to pay for the Medicaid, and we got our commercial payers to pay, as well as our Medicare program. And this is before Medicare covered SBIRT from our local Medicare intermediaries. So what I hope to show you is that if you can put a smart person on the financial path, calling payers and working with them, you can actually get these covered as well. Our state wasn't a totally enlightened state in the very beginning, but we had good people who were willing to listen and we met with. I'll cut to a little bit. I had to personally call all 3 of our Medicare intermediaries and talk with each of the directors and the medical directors about what SBIRT was. I had to personally meet with our Medicaid program, as well as each of our individual payers. I had to call each of the medical directors associated with them, their counsel, as well as I had to call and talk with not the vice presidents, but I got into most of the directors overall, like United Healthcare. I got into all of our local private payers and even our state-funded payers. So I personally met with them, and after just about 6 months of work, all of them were on board. And what I hope to show you is how you can bill for it, so you know ahead of time, as well as what you need to do in your discussions with these payers. And it's pretty exciting. It's not just our state. I'm working with other states doing the same process. And all it does is take a little education, as well as showing them how little the money actually is for them to pay, but how much, when you start doing it, how much it saves them. So with a little bit of cost up front, they can actually save money. And that's what we've been able to prove in Oregon as well. So Oregon, their motto is keep it weird. So I just want you to know Oregon isn't some perfect state that no one else can duplicate their success. We have a high number of weirdos, as well as people who are always fighting seasonal depression. We're not the perfect state, and we're highly democratic. So in a highly democratic state, we made it work. And I'm pretty sure that if you go anywhere else, you can make it work. And that's what I've been doing as well. So we've started work with Washington, and with Washington State, the next door neighbor, pretty soon we'll be up and running with SBIRT as well. And again, we're not the perfect out there state. We're a very weird state, and even in a fractured state like that, they were able to make it successful. So you can do it here, you can do it anywhere. So again, our approach to SBIRT was really, if you build it, they will come. So our provider said we need to have integration into our electronic health record. We have Epic as our electronic health record. So we have what are called smart phrases and things that are called smart sets. I'll have visuals to show you so you can kind of really piece together what I'm trying to say. Epic is probably right now one of the hottest electronic health records. Why it's so good is that you can customize it. And the customization, one provider can customize his note to say something. Another provider can take that customized note and himself change things and then create a completely separate note. It's for one of the things that we do. If providers are doing the same type of education over and over again, they can create a customized note that changes with patient information. And it's really seamless, and I'll show you examples of what I'm talking about. But Epic is great. Now, is Epic the only health system or the only record that health systems use? No. Centricity is very big, and there are other types of electronic health records and ways to use them. So the point I want to stress is that we have multiple electronic health records that we use, and we've integrated with this SBIRT initiative. So it's not that Epic's the best. It's just that most of our state in Oregon have moved to Epic. We've also worked with Centricity and made it very successful, as well as NextGen. And so it's not just that, oh, if you don't use Epic, you can't do what we're doing. No, it's just if you're using Epic, we have templates we can give you for them. But if you're using any other electronic health record, you could do almost the same that we did. So one of the things I jumped the gun on was our billing requirements. So like I said, Oregon Health and Science University is a major force in Oregon. But what I had to do is I had to personally meet with each payer. I had to personally meet with each of our Medicare intermediaries. And there's 3 of them in Oregon, because we have a federally qualified healthcare center, we have a rural healthcare center, as well as we have just the normal Medicare. And so the rural healthcare center had its own Medicare intermediary. The federally qualified healthcare center, our safety net clinic, full FQHC, it had its own Medicare intermediary, and then just normal billing, Medicare had its own through Noridian. So I had to meet with all of these, as well as our state Medicaid program. We were lucky that when we started showing them the evidence and the numbers, they were able to really push forward and get it covered. And our local payers, as well as our state-funded plans, covered as well, because that's where the push was. Now, did we have a great governor who pushed forward on this? We have a great governor, but he definitely wasn't pushing forward on SBIRT, and we were able to be successful. So what we've really been pushing is we really put SBIRT, and I like our word embed because I'm trying to make a joke, but we really embedded SBIRT in the billing logic into our OHSU, our electronic health record, and into our entire practice management system. So we really created documentation that flows with the clinician responses, and what that means is literally how the provider talks is how the note read. And providers love that, because when they talk to a patient and then they have to input it into the electronic health record, most of the time providers would take the 15 minutes to document if it didn't flow the way they wanted to, because it didn't feel like they were being honest when they were doing the note. So we literally created something that in less than a minute, or as we tell people, in less than 3 minutes, the provider could have the entire discussion for SBIRT documented and completed. And it flows with how they talk to the patient. And that was key. And I can't express again, if you try and force a provider to do something related to billing, you're probably 9 out of 10 times going to be unsuccessful with that. But if you work with the provider and even do billing behind the scenes, like I'll show you how we did, it works. We did a lot of front-end training. We did a lot of talking to providers, going to the clinics and discussing with the providers, working first with providers who said, hey, I'm interested, but help me. Can you work with me? We did that front-end training. And we used a lot of follow-up to teach our staff. So our facility, we have medical residents, so we have interns, second year and third years, as well as fellows. And they integrated directly with our providers. So the funny thing is, if we talk to a resident about this, we would be surprised how the residents would be training our primary care provider, faculty, and alumni on exactly how to bill for SBIRT, as well as vice versa. Some of our providers teaching their residents how to do it, but we integrated our teaching discussion for SBIRT into our residency curriculum. So what was really fun was, yes, we had some physicians who were interested in the SBIRT, but where a lot of push came from was where our residents were saying, hey, I was trained this, how come you're not doing it? And so all of our providers quickly jumped in board of, hey, what is SBIRT? And started billing for it, mainly because the residents are asking them, and I know they didn't want to look shy and sheepish saying, I don't know what you're talking about, yet I'm going to be the one training you. So a lot of them jumped on board quickly with what is SBIRT and how can I do this service. As well as we had Dr. John Munch, our clinician champion. And so that's why I have the Superman signal next to him. Something just as important as having a clinician champion is having someone at the clinic who has finance. And so all the people on the phone call today, you might be integrated with the health system. You might be a primary care doc who's standalone, who has his own clinic and isn't connected to anyone. You might be a mental health institution. You might be a licensed psychologist or a licensed clinical social worker. You might be working in a primary care clinic doing that function. You might be working in a mental health facility. You might be, again, a private practice, and you have a licensed clinical social worker who comes with you, or you're just a primary care doc, a physician assistant, or a nurse practitioner. SBIRT can work for all of you. There isn't a magic where you have to be a health system to have SBIRT work. We were fortunate that we created this program, but we've taken it all over Oregon, and we're at the small mom and pop where the dad's the husband is the clinic physician assistant or the clinic medical director, and the wife is the clinic administrator or the clinic office manager. SBIRT can work anywhere. And I'd like to, again, if you go to the, if you forget and you're like, this guy who spoke at this webinar, extremely boring, but he did say that On Google, if I typed in Oregon SBIRT, I can go there. If you click there, you can watch our training videos on how we talk with patients. You can see our handouts. You can actually get all the material so that you can start doing SBIRT the moment I get off the phone. It's all there, and it's all free. And not only is it free, but you can actually adapt it to your clinic, and so it's in a Word or PDF document. I just can't stress enough how the information is there. It's there and it's free, and you literally could start doing this the moment I'm off our call. Are there any questions yet?
I do have one other. I don't know if you can answer it, though. If you can't, we will answer it after the call. There's a person in Florida who's wondering who to contact with the state as far as SBIRT goes. They are currently using SBIRT and in an SBIRT program, but she would like to liaison with somebody to get more help with understanding where it stands in the state of Florida and how to use it. And
when I saw in Oregon and in Washington and in our other states, there was always a person in charge of the SBIRT program. Most of the time it's being done through the state's Medicaid alcohol and drug addiction program. So what I had to do in the very beginning was I called our Oregon Medicaid and I said, can you patch me through to the Medicaid alcohol and drug addiction services? And I need to talk to a manager. And that's how I got through to Oregon. I did the exact same thing with Washington, and that's how I got through with them. I'm working right now with South Carolina and North Carolina, and there are committees for SBIRT already created within there. But my first bet, because it's how it's worked with Oregon and Washington, would be call your local Medicaid program. I know when I said call your local Medicaid program, first thing you think of is, great, I'm going to be on hold for half an hour. And honestly, I was on hold for half an hour. So if I was smart, I would have had someone like an extern or intern call for me and just get the name and number of the person so I could call them later and call direct. But that's a start. That's where I started. Lots of also just going on the website. One of my states I'm working with, they had a committee already formed. So I had a person who was trying to form a committee with the governor, asked for my help, and I just Googled and I just typed in SBIRT implementation panel. And sure enough, there was already people in the state sponsored by the state who were working on it. And so I just sent them an email and got in communication with them.
Okay. We have another question. Are these services in addition to an office visit, or are the patients scheduled to come in for these services only?
The SBIRT billing codes are not standalone codes. So yes, they are all in addition to an office visit. So that means when you're doing your office visit, you will need to have a 25 modifier on the office visit, and you would add this new CPT code. And I'll walk you through in a little bit. We've got quite a bit of time to talk about it, but I'll walk you through the billing, and I'll walk you through if you're doing, okay, so there are many, many different ways to bill SBIRT. I read a lot of literature, and a lot of literature has a negative connotation to billing SBIRT. In Oregon, I mean, if you're billing under a federally qualified healthcare center, you have encounter-based billing. If you're in a health system, you have a facility fee that you can bill for. If you're a standalone primary care clinic, you have just the normal primary care codes. It's so different, and a lot of the literature focuses on only one part, which is literally like 10% of how people bill. So the other way 90% of people bill, it's untouched. So I kind of think that also that some of the healthcare, the people writing the articles, they also don't know the billing too clear. They have a great aspect of how to provide the services, but they don't know really how to do the billing, and they say some negative things because they don't really comprehend there are different ways to bill for SBIRT. But yes, for billing the SBIRT code in an outpatient primary care setting, it's not a standalone code. It's attached to primary care. Now there are some states who in the very beginning have said it is a standalone code, and so I've been able to show them the AMA, you know, from the CPT book, if you know what I'm talking about. Oop, I did it, acronym. The current procedural terminology book for coding, your CPT book, that I've been able to show them, wait a second, this is a screening code. It is not a standalone code. You don't have a patient come in just to be screened and then leave. So we've been able to quickly overrule those decisions. And yes, it is billed jointly with an office visit. Now for ongoing treatment, you can have them come in, And they wouldn't be billing SBIRT because you've already billed it once. The follow-up treatment can be included in an office visit, or it can be included in a drug addiction counseling session.
Joe, we lost your slide presentation. Did you? Okay, good. I was afraid we were going to lose you again. Okay, thank you.
No internet problem. So there are different ways to do the billing. We're going to walk through each of the scenarios I've been able to bill through, and we'll hopefully help you with some questions you have. Are there any other questions?
No, I think that's it. I think we'll break for about 5 minutes or so in about 20 minutes, and at that time I have a couple poll questions that I had forgotten to do earlier, so we'll do them at that time too.
Perfect. Okay.
Thank you.
So the SBIRT method, this is again taken directly from our website. There is the annual screening, there is the full screening, and there's the brief intervention plus the referral. So each of these things are very interesting. I'm going to my internet went down again, so luckily this isn't down, but my other I'm going to go back to the Oregon SBIRT webpage. And again, it's as easy as typing in Oregon SBIRT. Oh, and I even spelled it wrong, and it still came up. How ashamed. So in our presentation, we have what is called an annual screening. And the annual screening is right here. It is, as it says here, it says one question asked about alcohol use, one question asked about drug use, and it also includes the PHQ. For most of you know those are the depression screenings. I'm going to go ahead and pull up on my computer and show you exactly what one of these looks like. Oh, actually, I could be smart about it and go to my screening forms, and I'm going to real quick just download this. So this is the form we use at our Oregon Health and Science University as well as throughout the state and throughout other states. It's a questionnaire we give every new patient and we give annually. So in your electronic health record, I'll walk you through and I'll actually show you how we've set it up so it pops up annually. This is something we give every new patient to our family medicine practice. We give every new patient to our hospital admission, and we give every new patient for the first time into our ED or ER. And you know, patients wait sometimes in the ER for hours, so to them filling something out actually is meaningful. I'm glad that ERs have upgraded their TVs to actually have channels that work and have had even the kids sections, but most of the time they have plenty of time. So every new patient or every patient each year, so it's a calendar year, so if they come in January 5th, then January 6th of next year, a pop-up will appear where they ask these basic questions. So the alcohol part is how many times in the past year have you had 5 or more drinks in one day? And then for women, how many times in the past year have you had 4 or more drinks in one day? We have the drug question. How many times in the past year have you used a recreational drug or used a prescription medication for non-medical reasons? And then this is mainly because we're in Oregon, so maybe those sunny Californians don't have to worry about mood, but definitely in Alaska and in Oregon, these questions are very prevalent. So we have, during the past 2 weeks, have you been bothered by little interest or pleasure in doing things? During the past 2 weeks, have you been bothered by feeling down, depressed, or hopeless? So these are the questions. Usually they answer yes to any of these. The healthcare provider will talk about with the patient about them. It's interesting, too, how if we don't talk about it, that never solves anything. And some patients, and again, it goes back to, you know, and I might get people mad, but sometimes good parenting just means talking with your children instead of trying to be their best friend. And so this is the annual screening. Now the full screen and again, this is all on our website, that's where they have the paper form is handed out to the patient. I'm sorry, I got to click on the full screen and it'll tell me. So the full screen is different. This is where you have the audit or the DAS given to the patient because they answered yes to one of those annual screening forms. So the real key is the patient gets an annual screening. If they answer yes, then they get a full screening. What that full screening means is that the patient is given the audit or the DAS, which are located here under screening forms. Our audit and DAS, this is what we use for both of these. Again, it's free. You can download it PDF or you can download it on Word document and just put your own clinic's letterhead on it, understanding that happens. And the real goal is, once they get the full screen, this is that paperwork, they fill it out, and then they give it back to the MA, and the MA will then give it back to the provider. And then what is a brief intervention? These brief interventions can literally be done in as quick as 3 minutes. And this really works for some of our safety net clinics, where this might be the only opportunity you'll ever have to talk to a patient. Clinicians, they can actually take, it doesn't have to be 3 minutes, they can take longer, but there are some clinics where you won't get a patient to come in unless you do it. So sometimes those visits may take a little bit of time. And I'll explain how you get to that decision because we'll actually watch a video, and I really hope it works. I know videos over, they sometimes do not work when they're done on GoToMeeting, but I'm pretty sure we'll be able to have a way for you to watch our screening video. And then again, the purpose of this is just to motivate patients to reduce their use, to abstain, or to accept a referral for treatment. In the very beginning, we did have quite a few patients who didn't realize they had a problem. And so when we did our annual screening form, they either declined it, but then the next year they did it, or the third year they did it. And so some of our feedback was, I'm really glad that you gave those annual screenings because it literally took them 3 years to even fill it out. Some of these patients have serious problems, but the number one thing for people who have a problem is denial. So if we were to click on here on our website, it walks you through each scenario. So we have our annual screening. This is not billing the SBIRT code. This is just the annual screening. And then we have our full screening, and then we have our intervention if they test positive. And we have had patients who take the annual screening, but they score in the no-risk zone for the full screen. So, things like this happen, but if you don't invest in this workflow, it's really hard to understand if the patient has a problem if you don't ask. And it's interesting how some of our healthcare providers in the primary care side, they just don't have time. They're busy. But lots of providers in the ED side have time, as well as when you're in the inpatient setting. We have nurses who do this. It doesn't have to be a provider to get the reimbursement. Each state varies, and I'm sure we can, I'll have my contact information as well, and as well as you're integrated with a very detailed SBIRT unit who's hosting this conference. Each state's different. We can work with each state, and we can help them see the light. So this is our model: annual screening, full screen, and then brief intervention. And I think we're ready for our video, and hopefully this works. My fingers are crossed. If it doesn't work, you do have the option of, when you have this PowerPoint, I pasted the website. You also could just go to Oregon SBIRT, and this is there as well. But I pasted the information here so you could just type it in, and it would take you to the video. So getting a video over to you, do I give you access again, or?
I'll change it back to me. I have it ready.
Okay.
So this is kind of fuzzy, and if it doesn't work right, I hope somebody will tell me right away. I'm hoping that the sound will be good.
You had a serious car crash. You're lucky you didn't kill yourself or somebody else. What do you intend to do about the drinking problem? What drinking problem? Look, I had a couple of beers, my friend, that's all. Your alcohol level was 190. Clearly you had more than a few beers. Now, how much do you really drink each day? Look, I had 2 beers with some friends of mine after work. What's the big deal? Everybody does. And backyard and having a couple of beers helps me relax after a hard day. This time I got a little careless and so just to not make a big deal out of nothing. Finish filling me up so I can get out of here. Look, I'm a New York Doc, and I think I know when somebody's an alcoholic. I think you have a serious drinking problem. You better straighten it out. And you can get out of here as soon as they switch you up. But in the future, do not drink and drive. Have some sense. I mean, next time you might not be so lucky. Well, help me understand what drinking does for you. What is it you enjoy about it? Look, I work hard during the week, and having a drink or two after work helps me to relax. I mean, a guy to cut loose every once in a while. And my friends go out a lot, and I like to hang out with them. So it's a way of relaxing and enjoying being with your friends. Yeah. Well, I can understand that. Everybody needs to unwind. Now, are there any things that are not so good about your drinking? Not really. I have trouble getting up some mornings. I can't stay straight for most of the morning some days. Must make work more difficult. Yeah, I mean, the day starts out kind of hard, but I just, you know.
Whoops.
You had a serious health crash.
Yeah, that's the full length, I think, of that.
Oh, it is?
Yeah.
Okay, I'll transfer it back to you, then I'll get the next one set up.
Do you have the other video as well, the clinic one?
Yes. The good one?
The
Good example?
there was one it's www.
We saw both, Chris. Whatever.
Okay, yeah, I've got the other one too.
Okay.
Okay, Joe, since you got here, you had a pretty bad crash. Remember what happened? Not really. I remember leaving the bar. The rest is pretty much a blur. So you're unable to remember your injuries because of being at the bar. Yeah, I guess so. Sounds kind of frightening. Would you mind if we spend 2 minutes talking about your drinking? My drinking? What about it? Well, help me understand what drinking does for you. What is it you enjoy about it? Look, I work hard during the week, and having a drink or two after work helps me to relax. I mean, a guy to cut loose every once in a while. And my friends go out a lot, and I like to hang out with them. So it's a way of relaxing and enjoying being with your friends. Yeah. Well, I can understand that. Everybody needs to unwind. Now, are there any things that are not so good about your drinking? Not really. I have trouble getting up some mornings, and I can't stay straight for most of the morning some days. Must make work more difficult. Yeah, I mean, the day starts out kind of hard, but I just, you know, stick it out. Try to push a little harder. Sounds tough. Are there any other drawbacks to drinking? Crashing my car, kind of a drag. Need the car. And having to get sewed up like this isn't too much fun. No, I imagine not. We're just about finished here. And that should do it. So, on the one hand, drinking is a way for you to relax and enjoy doing it with your friends. On the other hand, it makes getting up in the morning more difficult. Breaking your car and having to be stitched up in gear, well, those are other painful consequences. So where does that leave you? If I can cut down on the drinking a bit, especially during the week. Yeah, I think that sounds like a terrific idea. Have you ever tried cutting back before? Yeah, I've done it before. I can do it on my own. You know, Joe, some people can cut back, but for some it's difficult. We find that having more than 14 drinks per week, or more than 4 drinks on any one occasion, could put you at risk for some serious problems. Not to mention injury or illness. If you find that after 4 weeks you're drinking more than that, well then, in my medical opinion, you benefit from some outside help. And I'd be glad to give you the names and numbers of people we can speak to. Now, about your drinking and driving. yeah, I know that's not a good idea. I'll find somebody else to drive. I suppose I can take the bus. That sounds like a great plan. Thanks for your help.
Okay, I will turn it back to you now.
Are you able to go into YouTube before we leave and just type in Oregon SBIRT, and the first thing that pops up should be the SBIRT Oregon primary care method?
Okay, second.
And then we can end on this video. I was hoping to show everyone, just so they know, that you can kind of, what I like about this video is it's the uncomfortable discussion that happens in the ER. And what is great is you can kind of see how sometimes maybe a provider would be hesitant because it's uncomfortable for them to talk about this. And you kind of see how, like, the banter. And, oh, on that YouTube video, if you can just at the header type in the SBIRT Oregon primary care, or SBIRT Oregon, yeah. And there's that video right there. If you could just click on that and let's see if this works. If it's a little choppy, this same video is on my PowerPoint.
Good morning. How may I help you? I'm Alex. I'm here to see Dr. Winkle. I see you have an appointment today. As I check you in, we fill out a form. It's called an annual screen. It's just a few questions we ask our patients once a year.
Sure. The annual screen is a short questionnaire given to all patients once a year. Patients who screen positive may be misusing drugs or alcohol and qualify for a full screen.
Alice? Hi, I'm Latanya. How are you?
Good, thanks.
Good. Take that yellow folder from you. I'll take you back to your room.
Okay.
Alice, you can sit on the exam table.
Okay. The medical assistant quickly scans the annual screen and gives a full screen to patients who score positive.
Okay, I'm going to have you fill out this additional form. You can make sure that you give it to Dr. Winkle when he comes in to see you, okay?
Okay.
Thank you.
The full screen is a 10-item questionnaire that places substance use into categories of low risk, risky, harmful, or dependent.
Alex. Hello. Hi, Dr. Winkle. Hi, good to see you again. Yeah, you too. So you're here today for the diabetes follow-up, right? Yeah. Great. And I also see you filled out one of our alcohol screening forms. Yeah. Do you mind if I take a look at that? Oh, sure. Great. Okay.
Answers on the full screen are total, and the zone is circled at the bottom.
Okay. So, Alex, when we added your score, it looks like you scored in Zone 2. And Zone 2 is what we call the risky zone. And it's called risky because even if you're not dealing with any health consequences now because of your drinking, it's good evidence that shows up the long term you're likely to. Okay. Things like
the physician conducts the brief intervention and then proceeds with the rest of the visit.
okay, so before we're through here today, did you have any more questions about your medication?
Yeah.
Okay, great. I'll just wrap up here.
The physician records that a brief intervention was performed.
And I look forward to seeing you 2 months from now. Okay, thanks. All right, take care, Alex.
After the visit, the physician drops off the screening form. Later, data from the form is entered into the electronic medical records. Under the medical home model of primary care, the front desk staff, medical assistant, and clinicians together carry out the SBIRT Oregon primary care method.
So now you've seen 2 different ways of doing this model. I'd like to take a 5-minute break, and then we can come back and we can really start digging into how to bill even for the annual screening that was given. So why don't I go ahead and we can just take a break, and when we come back, we can pick up our conversation.
Okay, yeah, that'll be fine. Everybody take a break, and so we'll do it for 10 minutes from whatever time you have now, and I will start with the poll questions when we get back.
Great, thank you.
Okay, thanks, everybody. Hi, everybody. It is 10 minutes after the break started. So I would like to, this is Chris, I would like to ask you just a couple poll questions so we can get to know you and get to know the audience a little better. So hopefully there's enough people still on right now. Here's the first poll question. And just answer what fits best. Let's see, I'm hoping you can see this. Okay, what is your current professional role? Are you a counselor? Are you a nurse or in the healthcare system? Are you a program or unit administrator? Are you part of a fiscal department or something else? Okay, I'll give it just another couple seconds here. Okay, I'm going to close this one now. I think some people might still be on break, and I don't want to hold this up too long. So we have 60% of the people, oops, sorry, sharing. Excuse me, just a moment here. Okay, so you can see it, even though I can't right now. So from the polls, we have 33% of the people are counselors or, there we go, are counselors, therapists, or social workers. 3% are nurse practitioner, physician, or physician's assistant. We have 15% program or unit administrators, 12% billing and fiscal staff, and 36% other. For the other people, if you would like us to know what your role is, please put it in the chat box or the questions box. Okay, we are going to hide that one, and I'll do the next poll. Okay, what field do you represent? What would be the closest match for you? Are you mental health, addictions, physical health, education, or EAP? Okay, I will close this poll now and share the results. I've got just about 70 people, or 70% participated out of 59 attendees. So out of our group, we're having 21% mental health, 59% addictions, 13% physical health, and 8% EAP. So I'm glad that there's a variety of fields here participating in this. Okay, 2 more to go. This is a simple one. Do you currently conduct SBIRT interventions yourself? Okay, I have another 70% participation. So I will close this and we'll see the results. It's not bad. We have about 41% said yes that they do the SBIRT interventions and 59% don't. And our last poll Do you see your agency using SBIRT, yes or no? And that means, are they doing it now, or do you expect them to do it? Do you know if there's plans for them to start doing it? Okay, well, that's really overwhelming. I'll share this last one with you. Of the group that's here today, 86% of your agencies or organizations are currently using SBIRT, and 14 said no, that there are no plans for using that. So thank you all very much for participating. Let's close this out. I will see if Joe is available now to start.
Right here.
Joe?
Yes, right here.
Okay, great. I'll turn this back over to you then.
Great. So we just left off showing you this video on the far right. And again, if you type in Oregon SBIRT or you go to my PowerPoint, there's a link you can copy and paste, and it takes you here to the sbirtoregon.org/method. And the video we showed is on the far right, and it's our way of integrating in primary care the screening process we've created. Now, this can work at a psychiatrist. It can work in any mental health office. It can work if you're in the ER. Our healthcare model was different, where we had licensed clinical social workers, unlicensed social workers. We had psychiatrists. We had alcohol and drug addiction counselors. All these people were integrated into our primary care model. So this is where it was very helpful for us, because a lot of times licensed clinical social workers are doing this discussion, as well as nurses in the ER were doing this discussion with patients. So the model you showed one video which took place in the ER, and it's that uncomfortable discussion with the patient who came in. I just love that video because it's gritty and it's real. The other video was best practices, how doing SBIRT in your clinic can work. So you have your annual screening where it's brief. You can set your electronic health record to have a notice that this patient's either new to your practice or it's been a year since they've been in. Then you have the full screen if they test positive. And then you have Dr. McDreamy. No, that is Jim Winkle. He is the project director for Oregon SBIRT, with donning a provider coat for that video. Really great project director, fun guy. He's the one who's really helped push the Oregon SBIRT and actually created this website we're looking at and built it from scratch. So very smart individual. We tease him a lot about this video. Anyway, so this is where you can go and you can see all of our training materials again. If I'm annoying everyone by bringing this up a lot, the number one question I hear is, where can I go to get this material? So in my presentations, I try and make that very clear. So kind of the reasons why we did this, our clinicians are always more likely to intervene because if we can remove burdens for treating the patient. I think there's clearly enough evidence right now that shows the power of SBIRT. And we also, one of the greatest things is providers can't do it alone. There is right now unsurmountable evidence that says that we're in a primary care shortage. I would also push that we're in a mental health shortage, because a lot of times patients can't, it's hard to get patients good mental health, and as right now the reimbursement as well, I don't think meets the demand. So doing SBIRT in the model we showed you with annual screening, this can be done in the ER when they present. It can be done when they're an inpatient after a surgery. It can be done in any scenario. And it can be done with the team approach. The team approach makes it so it's not the provider doing everything, because that's very easy for them to burn out. So here's the pipeline we were talking about, our clinic pipeline. In lots of graphs we have drips where there's issues and things cannot be done. We have the annual screening, the full screening, brief intervention, or the brief intervention plus the referral, and it's all connected to your electronic health record. So how we laid our pipe and our foundation was we had our screening forms. This started by training our medical residents, by training the reception, the front office, our front-end workers, and our medical assistants, and going to the faculty. Luckily, each clinic needs to have a physician champion. If you have your champions, whether it be, it can be the front office coordinator, it doesn't always have to be a physician. It could be a clinician, it could be a nurse practitioner, a physician assistant, a licensed clinical social worker. You just need that clinic champion. Our clinic tools, which are scorecards I'll walk you through, having an electronic health record and making it work for you, and then evaluation, which goes many ways. Evaluation by your clinic, evaluation by your providers, evaluation by the staff, how is everything going? It could go in any different way of what that word means. Screening forms. SBIRT, doing the audit and the DAST, and the pre-screen, all of these forms, they're required. You have to have these scanned into your electronic health record for billing. These forms to bill, they have to have completed an audit or a DAST, and you have to have it either saved in the patient's chart or scanned in and saved in electronic health record. And so we formatted this for our clinics. We actually just, and I'm going to show you later on in this PowerPoint. I hope I'm not frustrating two people by not getting to the billing just yet. I'm just trying to explain how we did it and then explain how the billing took place. And it's in 6 languages. Not all of those 6 languages are on our website. Some of those are just in our clinic drive. I would email the contact information if you have languages and see if Jim Winkle can send those to you on that website. The example, we actually showed you the video where the brief intervention was not clearly given. It was just him going through and doing a brief discussion, but it wasn't the true intervention. But here's like examples on us. You have to raise the subject, provide feedback, enhance motivation, negotiate with the patient, or just mark a box saying I didn't do it. But the audit and the DAST are so important, and having this information saved in your electronic health record are equally as important. So how it worked with us is our faculty, about 30% were trained in the very beginning. We had a 20 to 30-minute training. The residents, our medical residents, first year, second, and third years, and our fellows had around a 3-hour training, so that more than 90% of them were trained. And what's interesting, too, is lots of our interns start seeing patients day 1 to learn bedside and to really get trained. Sometimes it occurred months after they were already seeing their patients. Some it occurred when they were beginning to see their patients. But one of the great things for me was just understanding how by teaching the medical residents this, it actually empowered the physicians to learn it, because it's embarrassing when residents are telling them stuff that they have no clue what they're talking about. So this is some of our module goals was just, why SBIRT? So in our discussions with the residents as well as the providers, we just explained like, hey, why it was so important to talk about there is rampant drug overuse and abuse in Oregon, and SBIRT, it helps. It cuts costs. It's effective, and it's right now being recognized by primary care or mental health all throughout the state and all throughout the nation. There's barriers to treating patients in primary care. Luckily, mental health providers and drug and alcohol counselors, they're used to this. But I know primary care, some primary care providers were very uncomfortable. I love that ER room where you see the provider struggling to do the suturing, and he's lecturing the patient. And that's really real. That happens just like that scenario. I like the scenario where the patient checks in because that's also real. The patient can check in with a questionnaire. They really didn't even think about alcohol and drugs, and so they kind of find it odd that their provider's talking to them about it. So it's just interesting barrier, and by talking about it, I mean, that's the start. And then the screening, just describing like how our primary care medical home and how SBIRT can be done is important. Telling them about the scoring and how you can score the annual screen and the full screen, and then getting them into treating the patient. If they're low risk, risky, or harmful, or they're independent, then we need to start treatment. On the far right, it says method. So a lot of this was done with our just discussion, but a lot of it was done with the videos that are on our website as well, that you can walk at your own leisure, and you can see Dr. Munch and other people treating patients who have SBIRT and who have alcohol or drug abuse. And you'll see how they talk to the patients and how the patients interacted with them. That's on our website. Communication style is very interesting. You saw the ER, frustrated ER doc probably thinking, why is this guy drinking? There's different ways to communicate. I heard a good quote that, a good leader communicates the same message but differently to each person. Just knowing that each person interprets and communicates differently is key. And then how can I, in that communication, be motivational? And how can I make that patient want to change? And how can I bring it to their attention that they need to change? And there's the intervention. In our discussion, we did it, again, through lectures, videos, through role-playing. Role-playing is key. And on our website, we also have role-playing tips and tricks. So I would look on that as well. And then the referral for treatment. There's different levels of substance abuse that we can treat. Primary care, mental health, all of these things, all of these service providers, all they need to do is bring it up with the patient. And what's interesting, too, is in our conferences, a lot of people are, and I don't understand this, but I'm not a provider, so that's why I don't understand it. We get a lot of pushback where providers say, is this appropriate for me to talk to the patient about this? And I would feel it's more appropriate talking to them in primary care than talking to a corpse in a morgue who had alcohol and drug abuse, or a person who severely injures themselves. I mean, it's better to talk about them before they seriously injure themselves or somebody else. But that is something that we run across. Providers saying, is this an appropriate thing for me to talk to my patient about? And I think the medical evidence says yes. So again, how long, how often, fidelity. Are we going to have one provider going out there alone, or are you going to do it on a team approach? We took the team approach, and this team approach can be used in the model we showed you in any primary care clinic, in any ER, and in any inpatient setting. So just so you're aware, this is probably what it's going to take for you. With the reception medical assistants, usually there's a 30-minute training course originally just to talk about how to implement, how to have your annual screen, how to have it entered into the electronic health record, and talking to your staff about the administering the forms. Barriers, there's turnover. Your staff, most of us have fully trained someone to find out that they left 2 weeks later. We all face turnover. We all face staff meetings. They're too full with agenda items to even talk about SBIRT. And then we all face the problem of sometimes this might be a new role for somebody, and talking to them, this might be brand new for them. So it's us forcing them, I like the word forcing, it's us explaining to them the importance of taking on this task and why it's so vitally important. And I can't tell you as strong as I can that communication is so important. If you just flip a switch and say we're billing for this, you're just going to run into barriers. When you're open and you talk about it, you reduce barriers, and you actually get people on board. So here are some of the things we did to help make our efficiency improve. Having clipboards, this is a little copy of ours. It allowed the patient privacy, plus it acted as a flag to us and our clinicians so they knew that they needed to talk to the patient about SBIRT. Generally they run, because ours had our custom letterhead on around $6.50. Literally, you could just go to Office Max and buy a purple folder and say, this purple form is SBIRT. If you see it, there's an SBIRT screening in here. Or the patient's ready to have the doctor talk to the patient about SBIRT. So the provider's prepared. This was our readiness ruler. Really good. We ordered two for, it's $2 for around about $2 each for 500, sorry. This was great because our providers could have it in their coat pocket, and so they looked at the form, they could pull it out, scan down, and exactly know, if the patient's healthy with their scoring, risky, harmful, or dependent. Our approach was only to talk to patients who scored risky, harmful, or dependent. And again, this assists our clinicians in their brief intervention, and it really is pocket size. It's something that our mental health and a behavioral health team usually had taped to a desk, or they had it somewhere where they can pull it in their pocket or have it on hand. And if you are interested in buying this, I would go to the Contact Us page at our webpage, and we can put you in contact with Jim Winkle, and he can show you where he bought it from, and you can order those. Great, great tools. So there's a larger version, which I don't know the cost on that, but again, if you're interested, I think it's attached to our website as well, a copy of it. And this is stocked in our exam rooms. You attach them to the wall, and that way the provider, if they didn't have their card, could walk over there and just even walk and have a visual for the patient. One of the interesting things we realized is that visuals were so important with patients, having them be able to stare at something and kind of, when you talk to a patient, many times they're interpreted in their brain and it doesn't connect just yet. But having this, and you can actually point and say, look, this shows you're risky. Then they can see something saying it's risky. It's just, again, each person communicates differently. This is something we did in the very beginning. Now this has changed, and I need to explain this a little more because of our billing system. So I have different slides that really go into billing, but we had custom cards. So this says billing sticky notes. There were cards, and then there were stickies that we attached to all the computers, like in this picture. And it was a thing for us to put on all the monitors all throughout our clinics, because in the very beginning, providers were like, what are those codes again? Or even, what is SBIRT? And so it was a reminder for our providers, and it was a reminder, the question you asked of, can you bill these codes with visit? So on here, the 15 and 30 minutes or greater than 30 minutes, there's the CPT codes, and it says additional RVU. It's our way of telling providers this is in addition, and getting them incentivized. Not all primary care is about money. In fact, many of them are not about money. But having an incentive, financial, even pushes them to want to even to do it more as well. So some people might take offense to that, but as a finance guy, I understand that if a provider doesn't have money to have their lights on in their clinic, then all the care in the world can't be done that they want to do. So here's our pipeline. You know, there are always performance and tracking issues. If we don't perform this step, then we fail and the pipeline leaks out the water. If we're not tracking our providers and seeing if they're doing SBIRT, are the MAs entering the information into the electronic health record? Is the front desk screening the patients? All of these things can cause leaks in your pipeline. Our challenge to implementation was the accountability of the staff. Honestly, sometimes I feel like when you get into management, you just become a full-time babysitter. The other thing, and many of you who probably heard that think yes, and then some of you are offended. I was just kidding. But accountability of the staff and the clinicians is so important. The more you try and force someone to do something in healthcare, the less reliant they are to follow you. So being an advocate instead of imposing, that's what we kind of ran the thin line. You know, being an advocate for SBIRT, but when do you need to be a little pushy when a provider's just not doing SBIRT at all, and having that rough conversation, just why? Maybe they don't feel it's efficient. Maybe they're one of those providers who felt it wasn't their, they weren't the ones who should be talking to patients about alcohol and drug abuse. But having that discussion is important. Some of them, it just depends on your ability to change your electronic health record. You know, one change, adding one questionnaire, would that frustrate your patients to where they won't come back? You have to think about all these things. Reimbursement is complicated. I'll show you how we were successful as we continue. And then, again, preventative service versus clinic revenue. At what point do you bill for this? And at what point is this just included as a preventative service? And it's one of the caveats of why people should go to your clinic, because there's no cost. So all of these things really affected us in our decision with SBIRT. And then here's the key one. Who's using what? Which electronic health record are you using? Are you happy with it? I'll be honest that Epic, again, it isn't the cream of the crop, and it isn't the best electronic health record out there to date. Do I like it? Yes. Does everyone need to have it to work and do SBIRT effectively? No. But again, I'm going to walk you through how we used it in our billing in just a few seconds. So you read the slide ahead of me. It says successful implementation of SBIRT requires defining the workflows that will best allow adaptation to the core SBIRT principles in your clinic setting. And this is what ours was. The annual screening, the full screen, brief intervention, and brief intervention plus the referral. So our first principle was you have to facilitate the ER to work with you. EMR. I think we're all at the point where if we've invested millions of dollars, we've invested our time, we've forced a provider literally at gunpoint to use the EMR. You know, you use this, the electronic health record, you stop paper. If you don't, you're fired. Many providers quit and retired when electronic health record came out. They said, oh, I'm done. My time here is done. You've invested probably billions of dollars now in electronic health record. Well, you know what? It's time that the electronic health record works for us. And then the second point, but a really important core intervention, is regular and universal screenings in a medical setting. So being consistent is so important. You have to have this consistency. You have to make sure that you're doing your annual screenings on all your patients. If they've been here a year, you have to they have to be completing the SBIRT. If they had it a year ago, well, that's great. They had it a year ago. They need to have it annually. And I like the very second to last point where it says patient-centered change talk. Unfortunately, alcohol abuse and drug use might be an uncomfortable conversation. But you come to the point where if you don't have that conversation, who else will? And the transition between primary care and treatment services, that's also important. So if you have providers who are doing the SBIRT discussion, do you have a licensed clinical social worker in your clinic? Do you have an alcohol and drug addiction counselor? Are you incorporated with mental health? Or do you have a person they can see for treatment? Does the primary care provider want to assume treatment? So these are the questions that you have to have answers to as you start this process. And then, so here's our workflow, just so you can really understand exactly what I'm talking about. And I know this is a billing webinar, but for me, it's important to explain how we got to the billing part so that it really makes sense. I did a webinar about 8 months ago, and 56% said they would not be doing SBIRT. At the end of the webinar, we pulled the same question, and we were at 7% said they wouldn't. So I hope to really explain to you the full picture so that you really, really understand how actually easy it can be to bill SBIRT. So what we did is we had a regular screening, and so that was our annual screening. The validated screening tools. So in the very beginning, Jim Winkle sat down and he went to SBIRT. In his SBIRT discussion, he had the forms for the screening. So he has the audit and the DAS and the annual screening form. And he said these are required by Medicare, by the state to bill. They're required to be saved in electronic health record, and he took the materials required. He's stuck with alcohol, so there is a training curriculum for alcohol misuse. There are set rules. So he knew that if he started talking about alcohol and drug abuse, he had literature to go back on. I love the patient-centered change talk. You know, a clinician intervention that combines risk levels on those screening tools and with the patient's readiness for change. And then again, transition between primary care and treatment services. If your provider wants to take on the treatment for the patient, that's okay. If he wants to refer it out to a specialist who can do the treatment, that's okay as well. But you have to have a system that's set up for that. So again, this is the entire our entire EMR outfit and how it worked as well on our clinic workflow. You know, again, clear automatic tickler, hard stop that lights up during the check-in process. It could be for a year, 9 months. It doesn't matter, but you have to have a screening tool so you can capture those patients. I don't know many of you if you have a really skilled electronic health record, but Centricity, NextGen, Epic, all of these systems can do this. It just takes someone at your clinic or your IT guy setting it up and walking you through how to do it, and then you're training the staff. You know, I like how it says validated screening tools. That's just the SBIRT, the audit, and the DAS, the data that collects that you can help just to see if the patient falls into the risky zone or even alcohol dependency. And, you know, I love the communication. Alcohol use is a continuum. A risk stratification process that will automatically lead to a clinician doing an intervention if the patient falls into the risky zone. And having a hard stop. I like the patient-centered talk. It requires action driven by a smart text, reminding clinicians of appropriate change talk given in the patient risk level. And I can't wait to start talking about the billing. That's going to happen pretty soon. I'm going to move to the next slide because I've already talked about this. I feel like I'm beating a dead horse. But the real function of your electronic health record, having that tickler for the periodic process, it can be done. You just need to get your IT guy or a person who understands your electronic health record to help set you up. Input of patient risk and history, you have to be able to document and store that in your electronic health record or in your paper chart if we're still in paper chart. I think I did a survey saying that 42% still were using electronic health records recently. So, sorry, we're using paper. We're still in paper copies and not using electronic health records. So having that information stored is important. Teaching and promoting best practices, this is the part that's the most complicated because there's the provider side, but I think the thing that frustrates everyone right now is the reimbursement model for SBIRT. And that we're going to talk about how we were successful about. Recording the medical encounter, so there's this keeping your audit and DAS or your annual screening and having that saved in the electronic health record or in the patient's hard copy file, as well as your documentation. And then again, the facilitating efficient and effective billing, that is extremely difficult right now with SBIRT, but I really can't wait to talk to you about how successful it can be. So who can adapt the electronic health record? Here's our example. So to make huge changes, that had to go to our Epic headquarters to make. To make changes in our electronic health system that weren't that large was our internet group. And so that's the ITG is the word we have for our internet service. Sorry, not internet. It's ITG is our IT department within our health system. And so I actually sat with them. I had scripting from a provider of what they wanted to have the screening tool to look like, the smart text, and I helped them create it. And then after the IT department created what I gave them, we tested it with the physicians. So each individual physician got input, and then me being, again, the individual provider. So who can adapt the EHR or the EMR? It starts with the headquarters of whoever the vendor is for you. It goes to whoever your IT guy is. Some of your providers are smart and they know how to use the system and create smart text or create different phrases, and the group getting together can create something together, or the individual provider. So before I get into billing, are there any questions as of yet?
No, I don't have any right now. Thank you.
Okay, I sure hope we get some now. So definitely feel free to ask a question during our discussion. I love the question about billing so far. So in an outpatient clinic setting, if you are an alcohol and drug addiction counselor, if you are a licensed psychiatrist, if you are primary care, if you're a nurse practitioner, if you're a nurse, in Oregon, we were able to sit with our payers and get each of the descriptions of who could bill for this completed. I know many states are actually working on getting this script, but for you to bill, again, you can bill 99408. That work RVU is 0.65 work RVUs, and that's all in addition to an office visit. And that's for spending 15 minutes. In the state of Oregon, lots of our payers pay aggregate time. So that includes face-to-face time with the patient. It includes the time it took the staff to complete the form and enter into the electronic health record. So each state has different rules about paying for SBIRT, but in ours, it's like the time the provider takes to talk to the patient and do the intervention, as well as the documentation for SBIRT. And so usually it's a few minutes added on to the intervention. In the videos on our website, these are the videos of our intervention. So we have different providers seeing different patients, and our intervention is in here. They can range from around 5 to 10 to 15 minutes, and all of these videos you can actually watch later. I'm not going to, on these videos, I don't want to have you have the horrible choppy video, although it looked pretty good on some of the videos I was watching during our presentation today. But I don't want to force you into that on these videos. But they are very good, informative videos for you to watch that describe, well, how the provider went through the brief intervention. So if you provide the brief intervention, you can bill 99408. So most of the people who provide services, if you're not private practice and you're working with a health facility, you get reimbursed for your work RVUs. RVU stands for Relative Value Unit. It's part of a spreadsheet presented by Medicare, by CMS, each year. And the work relative value units change each year depending on new codes or depending on the time and expertise and mental and a lot of different attributes related to performing the service. So an example, if you were doing a very heavy surgery, there'd be more work relative value units for that because it takes into place the provider medical decision-making, malpractice. It incorporates all that into create what it is a relative value unit associated to it. Billing in 99211, CMS has depended that it's 0.97 is a work RVU for that. So if you're doing an SBIRT, it's almost doubling what you'll get paid for if you're paying providers off work RVUs. Your 99409, again, it's 1.3 work RVUs, and if you're doing a 99214, that's 1.42 work RVUs. So you're almost doubling what a provider would be paid for. So what we wanted to do is we showed our patients, we performed the SBIRT, and we showed our providers that you could get reimbursed for SBIRT if you just talked and did the SBIRT to the patients. The 99420, that gets paid to $7.23 to $18. What that code is, it's performing the audit or the DAST, but the patient scoring into the low risk. And we only talk to our patients when they scored high risk or into the higher risk category. And so you can even bill for completing the audit in the DAST, but it not turning out to be positive. So are there any questions with that so far?
No. But, oh, here, one just came up. In an FQHC that receives fee per encounter, will Medicaid pay additional dollars for SBIRT? This is from Illinois.
Yeah, so in Oregon and Washington, what they did is so for those of you who don't have FQHC billing information, I apologize. This might make no sense to you. But for those of you who bill in a federally qualified healthcare center, you understand that you get paid an encounter rate. Most states, whether you collect your encounter rate through a RAP report each month, or you do it every 3 months, or you do it at the end of the year, they do pay you extra. And what this means is you just get more up front and less on your RAP report. So it gives you more money at the time of service when you bill the code. So you would bill the 99408 on your electronic health record, which converts it to revenue codes for the state. But you bill your encounter rate of, which has a CPT code of 99408, 25 modifier, plus the office code visit you were billing for, and it bills the encounter rate to your Medicare, your Medicaid intermediary. If you're billing, like let's say we have Care Oregon as our Medicaid intermediary, and then we have straight Medicaid. So if we're billing our Medicaid intermediary, it pays us more up front and less on the RAP report. If you're billing directly to the Medicaid, if you're billing directly to the state, you're paid the same encounter rate. So what this does is it just pays you more up front for your Medicaid intermediaries, and it gives you that money up front instead of submitting it on the RAP. If you bill directly to the state for your Medicaid program, there is no actual increase in that. So for us, we have Care Oregon, which is one of our main Medicaid intermediaries, and what this did is it paid us $7 to $21, depending on the billing code, extra up front. And what that was great for was those things. We know if you are at FQHC, you know your fight is you're trying to get as many patients as that RAP report and have a report that is accurate. And you're always missing patients somehow because it's impossible to have a report that's 100% correct. And so what this does is it helps you get more revenue up front and you lose less. So I'm sorry if I went on a tangent on that. I was going to talk about that a little later, but I'll just talk about that now.
Just before you do, Explain what a RAF report is.
What an RAF report is?
Mm-hmm.
I have not heard of that before.
Oh, okay. Maybe they misunderstood you. That's okay. I'll get more information.
That means you're not hearing me right. RAP report, W-R-A-P, RAP report. So and this is depending on each state does it a little differently. In Oregon and Washington, when we see a federally qualified healthcare patient, we get paid a percentage up front. So FQHCs, they're a different reimbursement model. Instead of billing them by CPT codes, they're guaranteed when they see a Medicare or Medicaid patient, they're actually guaranteed through the federal government a set rate they'll be paid for each patient. So if I was, Medicare will send me a letter saying that each Medicare patient you see, you're guaranteed a payment of $100. Medicaid will say you're guaranteed a payment of $120. And so what happens is when you bill a Medicare or Medicaid patient, you're paid a portion up front. I'll give an example because I don't want to confuse anyone. If I'm billing Medicaid, Medicaid guarantees a $100 payment. In the state of Oregon and Washington, if we bill Medicaid direct, they pay us the $100 direct. If we bill a Medicaid intermediary, like an insurance plan that takes Medicaid, for example, Care Oregon pays us a small percentage, so they pay us $33. And then what we have to do to collect the rest of it is create a report of all the patients we've seen with the CPT codes and send it to the state. And then the state, whether we do it monthly, quarterly, or yearly, then cuts us a check for the remainder of the amount not paid. And the hard thing about this, as we all know, is that we sometimes will see a patient, and for whatever reason, the report we send the state might not have it on. And so we lose that opportunity to collect that reimbursement given to us. So that's what an encounter rate is. It's a way for the state to pay a set rate per each patient, but it's really up to the federally qualified healthcare centers to send them accurate reporting so they can collect all the revenue. And the example that person asked was, can you get extra revenue for it? You can't get extra revenue if you bill directly to Medicaid. What it does give you is it gives you more money up front when you bill those Medicaid intermediaries. And our example is Care Oregon. And so what that's helped us is we just get more money up front. So the inpatient settings differently. Everyone here who works in the inpatient, you understand that you bill a facility fee for the inpatient setting and you bill a professional fee for the provider. So patients being seen at an outpatient clinic will usually get one bill if it's primary care. If you are in an inpatient, patients will get two bills, one from a provider and one from the hospital themselves for the equipment, the specialists, the medicine, the room, all that is created into a very large bill, so which gets heavily discounted by insurance carriers. But providers can bill SBIRT on the inpatient setting as well. They can also bill patients in the emergency room setting. So patients on an inpatient visit, the providers can still bill the same 99408 or the 99409. It's in addition to their 99231 work RVU of 0.76. So what I'm trying to show is that even on the inpatient, you can get paid extra work RVUs. And if you're billing inpatient and you're not paid off work RVUs, you're paid off a percentage of what you bill. What I'm telling you is that now you're able to bill a little bit more and collect more revenue. So this increases your revenues on an inpatient setting. And you would use the same 25 modifier if you were billing an inpatient 99231. Now, I wish I could know, but I think a lot of you are connected to a hospital. So this might confuse some people. It might, the people who understand what I'm talking about, it doesn't. But if you're in an inpatient setting and you're a facility, so you're a provider who works at a hospital and you're also a primary care doc, or you're just a hospital, you're independent with any primary care, You have what's diagnostic-related grouping, DRGs. This is how the hospital will group things and bill Medicare or commercial plans. What it does is there are separate DRGs just for alcohol and drug abuse. And in Oregon, our revenue varied where it was around $50 to $350 depending on the payer, just for doing the SBIRT. So what I'm trying to say is, in the model I explained to you on the inpatient, where the provider can bill his professional piece and the patient gets a bill, and the hospital can bill their piece and get a bill, well, both the provider and the hospital can get better reimbursement for doing SBIRT. So whether you're in the emergency room, whether you're in the hospital, if you perform an SBIRT on the patients in there and the patient screens positive, so you perform the audit and the DAST, and well, that's what caused the patient to screen positive, so you perform the brief intervention, or a brief intervention plus a referral, and honestly, in the inpatient setting, it's very easy to go over 15 minutes. And in the inpatient setting, because of discussion and the patient sitting there, it's very easy with the family talking to go over 30 minutes. And so there's extra revenue that's previously been untouched for the provider until now, and there's extra revenue that's previously been untouched by the healthcare hospital. So the hospital can make more money and provide greater service to the patient, and the provider can make more money while providing greater service to the patient. Now here's the twist. There are so many ways to bill for this. So for those of you on the phone, there's provider-based billing. I don't know if anyone understands what that is, but it's a way with Medicare and Medicaid and any government payer, you can get paid a facility and a provider fee. Usually it's because you're attached to a hospital, and so provider-based billing is a way for treating Medicare, Medicaid, and commercial patients, even in an outpatient clinic, but you're still part of the hospital because you're within a certain amount of distance from the hospital. You can do what's called provider-based billing. And I wish we had a poll for this so I can see how many of you do this, but there's also facility billing, and that's just the same technique. If you're a primary care clinic attached to a hospital, you can bill facility billing. And what that means is if you have a drug addiction counselor, you have a licensed clinical social worker, you have any of these types of individuals, you can bill for them as a facility fee. And so what we've done is we've hired licensed clinical social workers or unlicensed social workers. We've hired drug and alcohol addiction counselors, and we set them up as a facility resource so they can have their own appointments in the primary care clinic attached to the hospital, and we can bill and get paid almost the same amount that a physical health care provider would be paid. There's home health care. So there's billing home visits and doing SBIRT at a home visit. There's also residents. Many of you who work at teaching hospitals, you bill for your residents under a facility fee program. So you can even bill for SBIRT and get more revenue when a resident does it. There's urgent care facility. Many of you are when you close your doors at 5 or 6 and you open them up again in your urgent care, there's billing for SBIRT on the urgent care setting, as well as billing under a federally qualified health care center, a rural health care center, a tribal or immigrant health. And then there's inpatient, your ED or ER or observation care, or just normal hospital admissions. There are so many different ways to bill this. Provider-based billing, this is, most people will get frustrated when they hear about it because hospitals are incentivized because there's so much overhead with the hospital. They're paid a little differently than just a primary care clinic would be. Your facility billing, that's also attached to a hospital because there's so much overhead. It's a way for you to have, if you are on the phone right now, and let's say you're a health system, you're part of Providence, you're part of Legacy, you're part of some health system, there's reimbursement that pays the same amount as if you were a physical provider. And so there's a way for you to make quite a bit of money having an unlicensed or licensed social worker in your clinic treating patients for alcohol and drug addiction. And it pays very, very well. Home health care, when you visit patients at home, if you're a home health agency, or you're a primary care clinic and you do home visits, not only can you get paid for your home visit, but you could do a screening, brief intervention if the patient requires, and bill SBIRT attached to a home visit. residents. If you're in a resident program, so you're a second year, third year, or you're a first year, when you're doing facility billing, you can bill for their work they do for a patient. I'm sorry. You're technically not billing for the work that they do with the patient. You're billing for the time and the resources used for billing for that patient. So if a patient comes in and spends 20 minutes, let me show you this. This will help explain a little bit what I'm trying to explain. When you're a facility and you're billing for a medical residency program, you can't really bill for the time and the effort that the provider, the resident, spends with the patient, but you can bill for the MA staff. You can bill for the facility which they fall under. So MAs, nurses, they're all considered a facility resource. So when they register and check a patient in, here's a facility worksheet that the coders use. All of these things have points on them. So when you check a patient in, when you get their chief complaint, when you get their pain evaluation, when you give them an immunization, when you check their pulse, when you do wound care, all of these things can create points which are checked off here. The time the room is spent with the patient, so you're not billing for the resident and the medical decision-making they're doing. You are billing for the time that room is used. And so these create points. If there's additional staff support, all of those are here. And all of these get created into facility fees. So level 1, level 2, level 3, level 4, level 5. In your mind, turn these into 99211, 99212, 99213, 99214, 99215. Relate it to that, and that's what gets billed to the insurance and gets paid. So here is where if you're a large healthcare facility and you currently don't have a licensed clinical social worker doing SBIRT, so let's say the provider realizes that the patient score is risky, does an intervention, and then does a referral, you can bring this in-house. If you're a struggling mental health provider, you can approach a health system and say, look, I can actually help you guys make money. So there's different ways to bill for SBIRT that, again, are highly effective and get paid very well. I know there's got to be some serious questions now. Can I maybe open it up and see if there are any questions?
I have from the same person. California cannot bill for more than one service per day. I'm assuming this will be a problem to add additional CPT codes to an office visit. Is that your understanding?
So great question you asked. If you are a federally qualified healthcare center or a rural healthcare center, you're stuck by a certain billing code, and that is if you have a patient who comes to the clinic and says, and is there for a sick visit, and let's say something happens and they say, I haven't had my physical in a year, well then you don't get paid for doing a physical and an office visit the same day. Strict rules that say you will not be paid. For many of you primary care people in here, you might say, well, wait a second, the insurance doesn't let me do that anyway. There's been a big change where now, like United Healthcare will pay 50% of either or of the whatever's the most expensive visit. So if you had an office visit and you had a physical done the same day, many payers now are either making the other visit incident to and bundled together, or they're paying at a reduced rate for doing a physical and an office visit that same day. Or they're not paying for both and denying it, saying they need chart notes. So it's kind of the same thing, but with a federally qualified healthcare center, you cannot see the patient that day unless you can see the patient if your FQHC is set up with mental health services or it's set up differently. Then you can bill differently for different services. Okay. So an example I have is we have a federally qualified healthcare center that can do professional medical services, can do dental, and has a mental health account. So if a patient presents, it would need to be documented separately under each account, but you can bill for an office visit for medical, you can bill an office visit for mental health, and you can even bill for dental the same day. The documentation has to be separate in each account, and that creates an encounter for each of the services. So that is how lots of health systems are getting through by doing a diagnosis. So the provider does the medical care, and then the provider, or he does a warm handoff with a mental health provider, or he does the mental health himself, but just has a separate documentation for the same day. And this actually works in any state. But if you're just set up as a FQHC for medical, you can't do mental health, then yes, you would need to do the SBIRT,
and then you would need to have the patient come back the next day or do some sort of warm handoff with a mental health provider or a medical provider to have the continuing care done. It's a rule they've put in place to make it, and it's frustrating because when you think about it, you know it's strict revenue. The state has so much revenue and they can't afford to do more than one visit on one day because people would take advantage of that in their mind.
Okay. Do you have to be associated with a hospital for a PC clinic to obtain a facility-type payment? Getting reimbursed for unlicensed social workers, MFTs, and drug and alcohol counselors is challenging for us to reimburse under Medicaid.
Yes, great question. Not yes to your question, sorry, but great question you brought up. So facility fee billing is, unfortunately, if you're a freestanding ambulatory surgical center, most of the time you're looped into the facility fee billing. If you're a primary care private practice, most of these visits are then billed under Incident 2. So what's the change as of 1999? A very smart mental health provider said mental health and primary care should be intertwined. So what this provider did is he hired he went to a primary care practice. He said, I'm a mental health provider, but I'm going to see you in your clinic for a mental health issue and attach it to primary care. So let me explain how this model worked because he's been very successful at it. Many patients suffer from medical diagnoses, but they also suffer from mental health associated with them. So what this provider did is he hired he's a mental health provider, but he's also MD. So what he did is he can treat medical and mental. So he hired a medical assistant, and this medical assistant would do a discussion with the patient, find out that they suffer from mental health disorder. Well, he would bill for the physical diagnosis codes. So a patient presented to the clinic, and he would bill for insomnia because the patient couldn't sleep. So that would be his primary diagnosis. But as it kept going down, you'd notice he couldn't sleep, he had a loss of appetite, and he would suffer from depression. So he would have a social worker or an unlicensed social worker treat the patient, and then he would bill Incident 2, the provider. And so the primary diagnosis would be insomnia, the secondary diagnosis would be like weight loss, and then the third diagnosis would be depression. So it's his way of combining the physical issues with the patient and billing it under the medical, and it was fully covered by the insurance companies and Medicaid and Medicare. We realized in 2006 they created those behavioral CPT codes. So those are the 99150 to 99155, where you can bill for a chronic illness under primary care. It would be helpful, though, if you would explain, the person who asked that question, can you maybe explain what your practice is so I can better tailor an answer to what you're asking?
Okay, I'm sure she will do that, and I can. No, it wasn't her. I'll wait for her to answer. Valerie, if you can give us more information on where you're practicing. In the meantime, I have 2 more questions. If you'd like to do them now, or
yeah,
wait.
You bet.
Okay, in a hospital, can a physician and the hospital both charge for SBIRT?
So yes, but it's not. They're not both charging for SBIRT. One person, the provider, bills the CPT codes. The hospital bills differently. They bill under DRGs, diagnostic-related grouping. They bill under alcohol discussion that way. So they're not both billing the CPT code. The healthcare provider is billing this for the inpatient service onto their inpatient, like this is a readmit inpatient. And the hospital, not the healthcare provider, is billing separately under DRGs. So yes, they can, and they're not incidental. The provider bills for his services and gets paid a professional fee, and the hospital bills for theirs and gets paid the DRG fee.
Okay. Here's another question. We are a SQHC in Iowa. We do have mental health. As an LISW, can the 99409 or G0397, code standalone and receive an encounter rate separate from the medical provider on the same day?
So in Oregon, we're able to because there's so let me go through our scenario, and then let's see if it matches what your scenario would be. Many places have mental health, and they also have physical health attached to them. Now, here's how a lot of times we bill for our services, and just tell me if this matches yours. We will have a patient present in our clinic, and he suffers from some serious depression, or he suffers. That's a bad example. He comes in, and we do an SBIRT and audit and DAS and find out he has drug addiction issues. And so our primary care provider will do the office visit, and then he'll refer them to the mental health provider. And then the mental health provider will take that audit and DAS, and they'll do a brief intervention with the patient, and they'll bill for the SBIRT code themselves. There's different scenarios you can do where sometimes our primary care provider will bill for the office visit and the audit and the DAS, and then he'll have the referral over to the mental health provider and do a warm handoff that day. So the provider will talk to the patient, do a warm handoff, and introduce him to the mental health provider, and then the mental health provider will do a brief treatment, and then you can bill under your mental health codes for alcohol and drug addiction depending on your state that same day as well. So there's different scenarios you can work out. You can kind of see how we've done it, and it has been paid. Again, this takes a little bit of work to see what your state does, but in Oregon and Washington, two separate states, you can get paid for that.
Right. This facility is medical, dental, and medical health.
Yeah, and so that's just like ours. So you can get reimbursed for that. All the documentation has to be separate. So the healthcare provider can't include all the documentation in the mental health. It has to be separately documented. You have to move the vitals and all the information over. So you have to. What I'm saying is you can't just have one giant note under the medical side. You have to document medical and then close your note. You have to document then into mental health and enter your vital information in there, and then document your mental health note and then close it. If you're a primary care provider doing both, you can't just have all the documentation under the medical side and expect to pass audit. You have to separately document for medical and then separately document for mental. And I only ask this because we get a lot of dental patients who come in with severely swollen gums and alcohol and drug addiction because they're having dental issues. And that's where some audit in the DAS have come in handy with SBIRT because they have severe alcohol or drug reasons, which is why their teeth are falling out and they're having problems in the beginning. And so that's how we run into this, and maybe you're running into the same thing. A lot of meth and drugs causes tooth decay, and well, you've seen those pictures of those beautiful people. They literally destroy themselves with drugs.
Yes, she's saying that their documentation is also separate for those different departments too.
Smart. I've had to help a lot of people do that because they haven't been. So very smart.
I have another kind of involved question. I am from UCLA, providing evaluation services, training, and technical assistance to the state of California and 58 counties. We conduct SBIRT training to providers, but have come across all county AOD administrators saying that they cannot bill for these services of unlicensed staff when they are trying to integrate staff and services with primary care centers. We are at a loss to explain, as we are not experts in billing, more so on implementation of SBIRT and brief interventions. The 2 services per day is a big problem here, since warm handoffs lead to significant no-shows. So we train on SBIRT and are faced with significant billing barriers for the AOD workforce.
Let me, at the very end of our presentation, because this is what I'm an expert in, because it could take a lot of time, why don't I'll have my email address. Whoever that person is with that really good question, I have a workflow I can show you that what we've used, and it's been really successful in Washington because this is an issue we were presented as well. At the very end of the presentation, I have my email address. Please email me and I'll walk you through it. I'll send you that attachment.
Yeah, And if you could send that to me too, I can
you
get to
bet.
all the attendees as well.
You bet. I'll do that. You also run into an issue too, where California has a really chaotic Medicaid program and Medicare program in the way the intermediaries use it. So it is a little different chaos as well. But the short answer is a lot of what we've been doing is incident to billing. So, but I have a workflow. I'll send that to you guys then, because that'll answer. I could take about 15 minutes talking this, or I could just send you that handout and it would answer it. Let me send that handout to you, and it'll hopefully answer that question for anyone.
Yeah, that'll be fine, and I'll remind you tomorrow if I don't get it. Okay, that's it right now for the questions.
Do you want to take a quick break, and then we can get back, and I can show you how the EHR works?
Sure. Okay, it's 3:15 here on the East Coast, so we'll catch up again at 10 minutes. 3:25, would that work for everybody? Okay, 10 minutes. I'll put up a slide showing that too. Thanks, everybody. Take a break. Okay, Joe, are you ready to start again?
I'm right here.
Okay, I will turn it back over to you then. Go ahead.
Great, so thank you, everyone. I know this has been a long time. Hopefully everyone's been able to refresh with a pot of coffee or water. So as we just finish up the coding documentation, in the state of Oregon, again, this just requires a little bit of talking. This is physically the medical side. Your DO, your MD, your PA, your nurse practitioner, your nurse or your licensed nurse practitioner or LPN, each state has a different word for them. LVN, LPN. We're allowed to bill for SBIRT in our state. Just so you know, many non-physicians, they get reimbursed at 85% of the physician payment. Ancillary staff, so like your health educators, behavioral health counselors, a lot of them have their masters, but they're unlicensed social workers, or they're licensed social workers, can always perform an SBIRT under the supervision of the credentialed provider. So that's where you have, again, incident to billing, where the primary care provider, the billing provider, might be a different name than the person performing the service. Some states, for the screening tools, you're able to bill the 99420. So that's when you do the audit in the DAS because the patient scored negative in the annual screening, and it made so that they failed that, and so they had to take the audit in the DAS to see where they scored. If they scored low risk, you can actually bill their insurance for giving them the form and doing that part without actually having the audit and the DAS turn into a brief intervention. And one of the important things, there's a sheet that HRSA printed out, which have the reimbursement codes, where it shows what the reimbursement would be for each of the Medicare, Medicaid, and commercial. And I'm going to go here and show you what I'm talking about on our website. Under our reimbursement, you've probably seen these $26 and $51. Well, we ran across something that was interesting and happy. Each location, if you have a contract, you're actually paid per your contract. So we realized pretty quick that our commercial plans were paying us around $60 to $90 for the 99408 instead of the $26.43 like we talked about. So our average turned to be $33 because there are some state-funded plans which pay that, but many of our commercial plans were paying $60 to $90, as well as some of our commercial plans for the 99408 were paying us at $130 for the 99408 instead of the $65.51. But taking an average for 3 years, this was the numbers we came up with. But we were surprised with greater reimbursement because of our contracts. So here's the main thing. If we code the services wrong, we usually have very, very upset patients. And to help us, here is the sheet I was showing you a second ago. So I've talked really about the 99408 and the 99409. Now with Medicare, we have two new codes that aren't on this sheet. There's a lot more CPT codes. And how do you bill for these services? I put this might date me, but I put a picture on here of the $6 million man. That's not much money now. For me, it's a lot. But the theme of this is you have to continually work on it and make it better. You can't just throw something out there and say, I'm done. The example of the $6 million man, he had to have upgrades. And that's the same thing we have to do as well. You can't just think you're done. So I have one more video. Are you able to go to the Oregon SBIRT page under Clinician Note and click on that video and watch it? Kristen, are you there?
Yeah, I am. I'm trying to pull
Okay.
it up. Let's see what I've got here. Okay, just a second. Okay, and where are the physician notes?
If you go to the SBIRT Oregon and you type under clinician notes, so you go to reimbursement, and then once you click reimbursement, you click under clinician notes. If you click on where the little place signal is, it'll pop up. Oops.
Sure. I'll tell you what, first of all, I'll just switch this over to my screen so you can see
Yes, please.
what I'm doing. I'm going to get rid of my other things here. Okay, so this is the reimbursement.
Yeah, and you go to the, yep.
Okay, here we go.
And then click on the little arrow, the arrow there underneath SBIRT alcohol.
Mm-hmm.
It'll take a few seconds.
Yeah.
It'll take a few seconds. Don't have to click it again. It just takes a few seconds to start.
I don't see anything swirling. I think maybe I have to click it twice.
Click it one more time and see what happens, yeah.
It just comes back. Is this in YouTube or somewhere else I can get it?
Yeah, I'll get that for you in one sec. If you go to my slide that's currently up, it's the web address to watch.
Okay, let me get see.
If you go to YouTube and type in SBIRT.phrase, thank you everyone for the audience. The trouble is these videos are so good that it would be an enhancement to watch this one.
Okay, and click on, and then what?
Type in SBIRT.phrase.
Doc, D-O-C?
Space, and then D-O-T-P-H-R-A-S-E, yeah. I'm sorry, dot phrase. D-O-T-P-H-R-A-S-E.
D-O-T.
Yeah, D-O-T-P-H-R-A-S-E.
S-C-E?
Thank you, everyone. It's D as in dog, O as in open, T as in Tom. And there you go.
Ah.
And phrase, yeah. And that's upload, yeah.
Yeah.
And it's right there.
We would like to demonstrate how it's possible to use a phrase within the Epic electronic health record to quickly and easily document the SBIRT process in a patient who is using alcohol. First, we'll type in .SBIRT alcohol. It will bring up the text we've created for this purpose. And we'll
Are you able to maximize that so it's full screen?
Sure.
And document that her audit score places her in
sorry.
low risk zone. Because of this, we won't pursue this further and mark that her low risk use did not warrant further discussion. Because we didn't spend excessive time counseling her about her alcohol, we'll take out the final section about the quantity of time spent. And we've documented completely the SBIRT process for a patient who's not overusing alcohol. Now let's try it using the same dot phrase with a patient at a higher level of alcohol use. Let's say that this patient's audit score places her in the harmful zone. And because of this, we'll proceed with further discussion. The next section gives us the menu of options that are possible for performing a brief intervention with this patient. Okay, we'll check all of these. This will bring up even further text and options. The next step will be to chart that we've advised she cut back to no more than 3 drinks per day, no more than 7 per week. Having assessed her readiness to change, let's say that she'll be a 5 on a scale of 0 to 10. We negotiated a plan and agreed that that should be cut back to the advised daily and weekly limit. Promptly agreed that she could from participation in a 12-step program. We'll ask that she return to check in 2 weeks to see how she's doing with this plan. And given that we spent significant time counseling her and with a brief intervention, we'll mark that this took 15 to 30 minutes of aggregate clinic time for the purposes of billing. And thus we've created our complete chart note for the SBIRT process for this patient.
So great, thank you. This was how we were able to, and that's on our website if you want to watch it again. And that worked perfect. I saw it looked like it was perfect, so thank you again.
Ah, okay, good. Let me get
it actually looked perfect when you made it big. It worked great.
Okay, let me get this back to you.
So what you just saw was our video. This is how we track the annual screening tool. So when this is a visit of our test patient, and it's how we can schedule an appointment. We're able to do what's in Epic called patient messaging. You might have just a patient pop up with your electronic health record. Then we can set it with things so that when patients present, pop-ups appear. So this was an example we have with our patients where this text automatically pops up, annual screening next due on 7/9 of 2010. It was our way in our beginning because we didn't know just yet how to make it pop up when the time requirement hits. This is how we could help. So every patient we checked in and we did the we did the annual screening, we would then put in a patient messaging. Literally took less than a minute, and that would automatically pop up when the patient checked in every time. Now that can get a little frustrating that a patient pop-up happens every time a patient checks in, but it was our short-term solution before we could get how to make it appear only when we wanted it. Again, this is the tracking the brief intervention. The real key is, did the provider rate the subject? As you read through what I'm about to show you, just think, did we provide feedback? Are we enhancing them? Did we negotiate a plan? Was it not given? Was the referral recommended? In our note, and I'm going to show you here, this is our doc flow sheet. So when a patient presents, this is what appears for the provider to document. So here under the encounter, under the annual substance abuse, these two slots are here, as well as our full screen, and when they have the intervention. So those things I mentioned, raised subject, provided feedback, all that information is here for the provider and the AMA staff to enter the information. So negative, positive, decline is right here. Zone 1, 2, 3, or 4, they text in here, and then simple yes or no's here. Now I can run reports and find out which patients we're doing this on in our Epic software. This is what it's called a smart set. So that note you watched, that is actually done here. Oh, I'm horrible at writing. So they actually click on this note, and the free text will appear below. Our diagnosis codes are right here. So again, the main one, this is usually what we use for when we bill SBIRT, counseling on substance use and abuse. But what if you're just screening for alcoholism? What if you're doing specified counseling? We added those as well. Now here's the main thing we did, and what it's really fun to brag about. You all know that there are more than just these two codes. So our provider said, you know, you've got to make it to where the EHR works for us. So when the provider sees the patient and opens this smart set, this all helps him with documentation. He will click these two buttons depending on his time, and we built into this smart set if-then logic. So when the provider clicks this code, because it's 15 minutes, the electronic health record will look at the payer. So if the payer is Medicare, it then changes the code from 99408 to the G code for Medicare. If the payer is Medicaid, it then changes the CPT code to whatever the Medicaid, if it's a managed Medicaid plan. If the patient has a Medicare HMOC, those Medicare replacement plans, it will then change it to whatever the Medicare replacement plan CPT code is that we set up. So the really great thing is we've now taken all those complicated CPT codes that the providers have to know, and we've made it so simple, and it's all just part of their documentation. So they've been trained on how to use this for documentation. They've never been trained, you have to code off of this. So this form's so quick because now the provider goes, great, my documentation is so much easier because it's all right here. Not really even thinking about this has to do with coding. Great. So here's the small view. Progress note, diagnosis. There are fields here for medication orders, for lab orders, for patient instructions, referrals for our consult. So I'm going to take you down one more, and now it's all expanded. So progress note is here, diagnosis are here. We loaded custom medication orders. This is what our provider said they most likely prescribe. Lab orders, because this is what they most likely prescribe. Our patient instructions. And here's how we worked into our consult so our licensed clinical social workers could treat the patients. So we can do referrals or to our alcohol and drug addiction counselors or to our psychologists or psychiatric help. Here's a copy of what the smart set looks like. So Mr. Epic was given you can click both, and then the audit and DAST will appear, or you can just click audit or DAST. Mr. Epic's score placed him into the low risk, risky, harmful, dependent. Sometimes people didn't want to talk about it. So the patient expressed an unwillingness to talk. The patient's low risk did not warrant further discussion. We ran out of time and scheduled a follow-up visit for further assessment. So we literally created this note so whatever we needed could be entered. In discussing this issue, my medical advice was that Mr. Epic, abstain, cut back to 4, cut back to 3, no more than 14 drinks per week or 7 drinks per week. Patient's readiness to change was, scale of 1 out of 10 on a scale of 0 to 10. We explored why it was not a lower number and discussed the patient's own motivation for change. Basically, we have all the medical discussion making right here. And what we did is when we called our Medicare intermediary, when we called our commercial plans, we gave them this saying, this is our medical documentation, is this sufficient? And so we have emails or sign-offs from each of them saying this is sufficient to bill. So this language for progress note, if you go to Oregon SBIRT and you go under clinician note, it's right here. So everything we just went over is right here. If you I sent this documentation. This was sent, and so you should all be getting it soon. This was our template for our SBIRT Smart Set. So this is what I sat with the medical providers, and I said, what would you like to have in here? So they gave me the codes they need to use. They gave me the meds they used. And I'm sorry, these numbers here are all just associated with Epic and how they order. They gave me the labs they wanted to order. They gave me their patient instructions, the referrals they wanted for our clinics. And then here are the CPT codes. And then here was the rule we put in there that changed the code. If the payer is Medicare, the CPT code is 99408, and then it changes it to the G0396. Now there's more codes, which we had to update this to say. But basically, we created the logic so that our electronic health record worked for us. So I sent that handout. You guys have that to look at. I also sent a copy of the
SBIRT Epic Smart Set, and we can go over that again if you need. This is a smart set and a smart phrase are two different things. I'm sorry if I'm going so fast, it's making people dizzy. So when I click down here, a smart set opens up, and like if a provider came for a routine office visit, then you click routine office visit, and this pop-up would appear, and it had all the codes, and it had this ICD-9 codes you could put in. It just makes it for faster documentation. And in an Epic Smart Set, there's a thing called a progress note, and that's when you click on that box, this appears. And this is the custom note, so we could quickly document the SBIRT, because as healthcare providers know, if you see patients for 8 hours a day, that usually means 2 to 3 hours of notes. So now instead of saying, I have something new for you to document, that's what providers hear. Hey, I've got this new service. Well, providers think, great, I have to document more. Oh, great, I've got to bill something else that I don't know is going to get paid. Oh, great. So they think of these things, and so we help to answer their questions. So how we really sold this to the providers was we've got a new way for you to have this medical documentation. I'm going to move this back over here. I apologize. This is getting kind of dizzy. What we're able to tell providers is, look, we have a way for you to document the screening, brief intervention, referral for treatment quickly, efficiently, and literally in 3 minutes you could have your documentation completely done when it could be 1 minute. We gave them what diagnosis to use, medication orders, what lab orders they commonly use. We gave them patient instructions, a level of service, and one thing hidden here is they can do ad hoc orders too. So what we gave them was a thing to follow. If they wanted to order anything else, either their labs, medications, they could free text that information and order it there. So what they could do is in their office visit, they could actually click on this smart set and document SBIRT and then keep doing their office visit as well. So have I confused anyone yet? What I'm showing you here is a way for us to teach providers how to document and for them to document a new service without really scaring them on coding, because we made it all work behind the scenes.
I have a couple questions. One of them is specifically on what you just went over. What is the feedback, both positive and negative, have you received from providers that have used this system?
Great, good question. So the feedback we received in the very beginning, you see there's a code missing on here versus what we originally had. We did have feedback because we could build a 99420 when they do the audit in the DAFT and the patients don't score into where they're risky. So we did have under a level of service there the 99420 where they could have built that code. And the feedback from the providers is we felt they were nickeling and diming the patient too much, and to take that off, they didn't feel comfortable billing that code. And it was hard for me to do because we collected in just a few months of doing it around $4,000. So if you think about it, if we're getting paid $18, that means per patient that we had quite a bit of patients who were doing the SBIRT and not failing. They were not into the too risky zone. So as a revenue guy, I'm like, that's money, and if that was just a few months of doing that, a full year, I mean, imagine making $60,000 off of screening tools. So that was, but the provider feedback was good because they said, well, we don't want to have upset patients. So the feedback we got actually from the providers, they really liked the diagnosis codes. They originally we had a lot more, and they asked us to shorten them down to just these 4. The one main point is they only really wanted the counseling on substance use and abuse. The other 3 we added were because some of the providers also talked about other things, and they wanted to have multiple ICD-9 codes. And ICD-9 is International Classification of Disease. We're currently on the 9th clinical modification. We all have heard about ICD-10, so I won't even talk into that. I feel like it's a swear word when I say it. But ICD-9, though, they wanted those codes, and they wanted them shortened down. All of the providers I had yet in the 3.5 years of instituting this, received even a negative thing about the SBIRT smart phrase. The phrase itself, this thing we were showing you, they absolutely loved it. luckily there was a provider called Meg Hayes. One of the most, what I loved about working with her was she was brutally honest. So she, when it comes to the filter, sometimes she just says exactly what she feels, and it's rare to find people who are like that. And so she actually helped me. I sat down with her a few days, and we went over this again and again, and she helped me create this. And what was great is she was to the point. And so instead of me wasting time creating something that providers couldn't use, she helped me create something they could use. And as we were teaching the residents, they loved that their documentation was easier, and the medical providers liked that there were options. So the feedback we got was make it so we can free text if we need to. And as you see on the smart phrase, there's these little asterisks where they can click that and they can free text. So we basically gave them, they had an option to use this information, or they could free text what they wanted to write. So the providers liked the ability to not be constricted, and that was their main point. They needed to be able to write what they needed to and not be constricted to what we were giving them. The last piece of advice that they gave us was to condense the medication order, lab orders, and patient instructions so that when the note opened up, only progress note, diagnosis, and level of service opened, because they didn't want to get confused. And they know in their brain, I have to have a progress note to bill, I have to have a diagnosis code to bill, and I have to have a level of service. So they know that. And so that's what it opened. And then if they wanted to do medication orders, lab orders, or different instructions or referrals, they liked the option of doing it, but they wanted it to open to just the basics. Are there any other questions?
Yes, I do have a couple if you want to do them now.
Sure, we've got a little bit of time.
Okay. The video showed documentation with regard to treatment plan to include 12-step program, etc. One of the concerns, apprehensions with regard to SBIRT documentation in the patient's chart has to do with vulnerability of the insurance company denying to pay for treatment because alcohol was involved. And this person is speaking from the point of view of being in trauma or an ER situation as it pertains to accidents or workplace injuries. Can you address this concern?
Yes. Our state is a state where some states you cannot bill for treating accidents related to alcohol. In Oregon, they removed that law, and so now if a patient's involved in an automobile accident, what I'm trying to say is some insurance companies would not pay for the accident, saying that the patient has to pay. We're a state that doesn't have that restriction on us anymore, and so that helped remove that barrier with us. And you know, patients sometimes, I don't think patients will talk like if it's like psychotic episodes or there's issues they're talking about. There is a way to restrict that. So unless it's a subpoena, there's no reason the insurance should be looking at that. So this is the difference with Oregon where we don't have that ruling. Scrolling down a little bit more here, under see the big picture, I'd hate for that to be a barrier for a person to provide SBIRT on the what ifs. And so we ran into that same discussion where what would happen if we did this. What we realized is that unless we pioneer something, the what ifs would ruin our ability to do the SBIRT. And luckily, we haven't had that as an issue. We've gone over this. I put that in here again. Here's a little cleaner version so you can read it. This is our SBIRT note and the IC-9 codes. The SBIRT does pay for counseling on substance use and abuse, and our commercial payers paid for these services. So in our state, it really wasn't an issue when it came to paying or asking for chart notes. So and our patient feedback too is our notes are 100% confidential. So unless they authorize us to send the notes to the insurance, or if there's a special thing they want us to not mention about, we could flag the accounts that wouldn't be released unless the patient provided authorization for it. And believe it or not, we have not had a request for chart notes yet on our SBIRT. And that could be because we were open and sent this all to our medical directors of the health insurance, and we were very open with them about our documentation standards.
Okay. Just a question for you. I still have 2 more questions here, and was wondering if you would be able to take the time to answer these before we cut off the, the webinar. We'll let it run a little bit longer. If you can take the time.
Yeah, I can. I'm fine.
Okay, so I want to tell everybody, I've already had a couple of emails of people who have to leave. This webinar is being recorded, and by tomorrow around noontime, it will be in our webinar library. Everybody, within a couple hours after this webinar ends, will get an email with information about getting your CEUs. It'll also have a certificate of attendance, and it will have an evaluation link, which we really hope everybody will do. It's very, very short. It's under 2 minutes, and it's an evaluation of this webinar. So look for that in your email, and I'll also on Friday send a reminder about that, and also send the same information again, the handouts and the links. So
I've got a few slides left.
now. Thank you for attending.
I've got a few slides left before the time ends. Let me go ahead and do that,
Yeah,
and I
go
can answer
through those,
questions.
and then we'll get to these questions. Thanks.
Yep. So I attached the form for the audit and the DAST here. I just wanted to quickly scroll down on here, and let me make the view a little smaller. I hope I'm not frustrating people too much. So on the very bottom are the scoring that you saw in the video with Jim Winkle, where depending on their score, it placed them here in the 1, the low risk, the 2nd, risky, and so forth. So I have the forms in the PowerPoint that you can really look at. Here's a copy of our DAST filled out. I wanted to give you a real-life example of what we work with and how a patient would sign it out with the patient information taken. Again, here's our annual substance use, the positive, and the risk zone, how it looks like in our electronic health record. Again, this is just what a progress note can look like with the patient information taken away. This is a dummy patient. But I just wanted to show you how in our demo for reimbursement, again, our real point of why our program was successful was we trained the providers up front, and we made the billing, the back-end billing, part of the documentation requirement. So in our trainings, we didn't train them how to bill, we trained them on how to document, which providers don't glaze over if they jump on that. This is what I need you to do to document? Okay. You tell them this is what you need to do billing, they'll probably think, yawn, I'm done. So in this presentation, my main focus is SBIRT can be embedded in a hospital system. It can make money for the hospital, and it can help the patients get better care. Business and billing, you can integrate them. In business, like the patient care can be improved, and your clinic can make revenue. It doesn't have to be an either-or. And by using your electronic health record and making it work to its highest degree, we can't always expect the providers to work to their highest degree. We have to also push for our electronic health record to do its best. And then be able to change. If we're doing one thing, we can't say this is your smart phrase and you're going to live with it. We've got to be able to consistently meet what can be improved upon. What can we do to make this better? A good example is we didn't just give them the smart phrase and say, you use it because we created it, and if you don't, you're not billing right. We gave them the asterisks where they could change what they wanted to. We gave them the options to make it successful. So we can improve patient healthy outcomes by putting an SBIRT program in a hospital. We showed that can work. Any health facility can run a successful SBIRT program with preparation and dedication. You don't need Epic to work, to make this work. You can have Centricity, Nextra, and Meditech. I hope I'm trying to show you that you don't just need that one electronic health record. If I had that one, it would work. No, any of them can be built to make it work. Honestly, I always stay away from the always word, because when someone says that's always how it's been done, a red flag goes up and I think this person is wrong. But honestly, with the electronic health records, you need to make it work to its highest degree, and it doesn't have to be at a huge cost to your clinic. And then as I end, here's my 2 email addresses, and I like my my picture on the right. Whoa, watch where that thing lands. We'll probably need it. Honestly, if you have questions, I've attended many webinars where when I sit down at the very end, I say, did this person really know what they were talking about? Or I say,
I really feel like they didn't get to the information I needed. If you have questions that we haven't hit, I can stay later, or you can email me, and I've done it. I've worked in healthcare now 15 years, and all of it's been in revenue cycle. I've had from the front office to dealing with providers and training them. I've lived what you guys are fighting. And if you have questions that are specific to your state, or if you need help, honestly, that's what I'm here, and that's why they signed me up to this webinar. If I can help you, even if it's the tiniest question, I am here to help. And I've had those webinars where I've really thought, I don't think the person who presented knew what they were talking about. But I can honestly tell you, I know what I'm talking about, SBIRT. I've done it. I've done it in various states, and it can work. It can work in any organization. It really can. It just needs someone dedicated to it. And thank you for your time.
Okay. Here's the first of the two questions. In regards to the previous question with billing for LISW under FQHC, they just want to clarify, see if they've got this correct. An LISW has to perform under her or his scope of practice in order to bill a separate encounter for the same day as a medical visit. An LISW just can't perform 99408 or 99409 for it to justify as an additional encounter rate for the same day.
How a lot of times how we get those providers entwined is the healthcare provider can do this screening. They can bill for the office visit and the brief intervention, and then they also can refer the patient that same day for a visit. And that's how we can get medical done, because the documentation's there, and the patient will go to the next provider and have a medical. And they move from medical to mental if you're adding a specialist within their scope of service. So it would help if they were to tell me their state, so I can get the state rule. In Oregon and in Washington and in many states that are FQHC, you're right. The key word you just mentioned is scope of practice. And mental and medical don't mix unless they have their separate encounter rate, and then they do mix. So a provider can do a warm handoff for mental and get that covered under mental. We also have some providers who do mental health services and medical. And so they will do a medical, finish their documentation, then open a new encounter and document under mental. And when they're documented under mental, they can also have a specialist come in. And so the specialist can do a large portion of the mental as well as the provider's done their beginning documentation. And that's how we paid for some of the services as well, because the mental was done. And even though the provider did a little bit of it, they did the sufficient for billing, and they had a second person come and finish it. And how we've been able to justify this and with our cost is more of these visits can get done by one provider than can be done if it was all under medical. And there's different things I can talk to you about. This probably can be its own long half-an-hour conversation where I can explain to you exactly how to bill for your services.
This person's from Iowa.
Oh, good, good. Okay. Well, you have my contact information. Feel free to email me, and we can talk about the specific scenarios that you face, and I can walk you through scenarios that I've worked on that have been successful in paying, as well as past successful Medicare and Medicaid audits.
Okay. Here's a question from Nevada. How do you suggest we motivate providers to provide SBIRT services when their patient base is basically Medicaid and Medicaid does not cover these services in our state?
So one of the things that we've done to help motivate our providers, if you're screening for a brief intervention, okay, let me back up. One of the things that worked great for us, if you're a teaching hospital, teaching your residents has been amazing, because then they make the other providers want to jump in and know what they're talking about. But the question you're really asking for is, how can you motivate a provider? So some providers are motivated by money, and you just made a presentation. You just made a statement that Medicaid doesn't cover for SBIRT. So when you're doing a discussion with patients about alcohol and drug abuse, Medicaid does cover for that. They may not cover in your state for the billing of the SBIRT CPT codes.
and you only bill an SBIRT if you do a brief intervention or a referral for treatment. Medicaid does cover the discussion of talking about alcohol abuse. And there, you have your own separate ICD-9 codes to talk about that. And then that's used to upcode your 99213 to 99214 for medical decision making. Because you're not doing a brief intervention or a referral for brief intervention. You're doing discussion with the patient related to their alcohol abuse in medical discussion making. So lots of times clinics don't do the audit in DAS. They do that verbally with the patient, and they don't actually have that scanned into the system, so they bill a 99214 for time and discussion. Because to bill an audit in to bill the SBIRT, you have to have an audit in DAS on file and do a brief intervention. So what I'm trying to say is that to get around it, how they've had to work because the Medicaid hasn't been good, is they have billed an office visit, and they've done the audit in DAS verbally. So they've basically had medical discussion with the patient, saying, I notice you're having an alcohol and drug addiction problem. Let's talk about this. Let's talk about, and so they're just doing counseling. The real answer to that, though, is we really should get the state to start paying in Medicaid and Medicare. And that's where having a frank conversation with the state, and I'm showing them some of these numbers, showing them, I had to show them, and luckily Jim Winkle was a great expert, and he is very willing to go state by state as well and help facilitate that conversation with payers as well as me. So we've had that frank conversation. These are the costs you could save. You're already at a high expenditure, so why not reduce your emergency room visits for alcohol and drug addiction? Why not talk to your patients who are Medicaid? I mean, you want us to reduce costs. You don't want to add costs. And that's how we approached it with the state, and they listened.
Okay. No more questions. Although I'm sure you're going to get plenty of emails.
I might. Well, no, hey, thank you again for your time. This is, it's always fun. I've lived SBIRT for the past 4 years, and luckily I've been able to make it successful in Oregon. We are self-sustaining, and it's fun. Every state can work on this. Arizona, all these different states, North Carolina, South Carolina, they're changing. And it's fun knowing that there are advocates for SBIRT out there. And I think we all know that the mental health has not had the funding it should have, as well as your alcohol and drug addiction counselors. I can't make more of a point that mental health and primary care don't have to be distant cousins. And there's primary care and mental health probably should be reimbursed a lot more than they are. But unless you make that fight, and unless you talk to your Medicaid, nothing's going to change. And luckily, Oregon and Washington are 2 examples that states can change.
Okay. Well, thank you very much. Again, to all the attendees, please look for an email from GoToWebinar. In just a couple hours, it will have the links to your CEU order form, certificate of attendance if you don't need CEUs, and most importantly, the evaluation. It will also have the link to where you can find the webinar tomorrow and the PowerPoint if you want to watch it again or review it with coworkers. So thank you very much, and I will stop the recording now and end the webinar.